listening to him, you realize what he's gone through. He is able to recall the delirious state he was in. Can you all hear? Did you all hear? Can you all hear him? Can you all hear what he's saying?
Can you repeat again, please?
අරංගියාට පස්සේ ඉස්පිරිතාලේ ලොකු කාමරයකට දැම්මා. ඒ කාමරේ ඇතුලේ ඉති කට්ටිය ගොඩාක් එක්කවුණා මට ගහලා මාව මරන්න හැදුවා. මරන්න හදනකොට දෙන්නෙක් එක්ක ඇවිල්ලා මාව බේරගත්තා. බේරගෙන ඉවරලා ඉන්නකොට මට ඒක ඇතුලේ ටිකක් වෙලා ඉන්නකොට දැක්කේ කොට්ටාව තමයි මේ කියන්නේ මේ බිල්ඩින් එක මාව මරන්න හදන තැන කියලා හිතලා බැලුවාම වටපිට කොට්ටාව නගරේ වගේමයි ගස් කොළන් ඒ බිල්ඩින් ඔක්කොම පේන්නේ කොට්ටාවේ නගරෙ තිබිච්ච ඒවාමයි. ඊට පස්සේ මම ඉමීට හිතාගත්ත මෙතනින් කොමාරි පැනලා යනවා කියලා. පැනලා යන්න හදනකොට මට මේ කට්ටිය වට කරලා ඉවරලා මා බිම දාලා ඉවරලා මට එක්කෙනෙක් ගහලා බිම දැම්මා. දැම්මට පස්සේ මා වැටිලා හිටියා. ඉන්නකොට මම අර බේරගත්ත කට්ටිය දකින්න නැහැ අනිත් කට්ටිය දකින්නත් නැතුව ගියා. ඊට පස්සේ මාව ඒ බේරගත්ත කට්ටිය දකින්න නැති වුණාට මට ඊට පස්සේ කල්පනා වුණා මම මේ කරන්නේ මොකද්ද කියලා. ඊට පස්සේ ටිකෙන් ටික මට හොඳ වීගෙන එනකොට මට මතක් වුණා මම මාව ඉස්පිරිතාලෙට ගෙනිච්ච ඈතට ඉස්පිරිතාලෙට ඒ ඉස්පිරිතාලේ තමයි ඉන්නේ කියලා ඉවරලා ටික හොඳ වෙනකොට ටික මට කල්පනා වුණා මම ඉන්නේ ඉස්පිරිතාලේ තමයි කියලා මතක් වුණා.
බොහොම ස්තුතියි.
Right. So this is an example. This is what a patient who has undergone delirium, he's recalling what he went through. He was totally disoriented. Generally, they are not, it's time, place. Now he's totally disoriented to the place. He thought he was in, when he was in Vadra hospital, he thought he was in Kottawa, somewhere else. And then the paranoia is there, okay, amounting to persecutory delusions. So you can see what a lot of distress it causes the patient in delirium. Okay, so when it comes to causes of delirium, there are a number of causes, but some of the main things are these. In age is, of course, in people who are elderly, these are one of the main causes of delirium, what I put in red. So you don't actually, miss out on those things. Infections. Even if it's a small infection, sometimes if they have other complications, it could cause delirium. One of the culprits is a urinary tract infection and chest infections. Those two cause a lot of, are very likely to cause delirium. So you have to watch out. Withdrawal of alcohol, very important, not just alcohol. Some of them are on benzodiazepines. So withdrawal from benzodiazepines can also cause delirium. Okay. Acute metabolic states are also known to cause. Then trauma, if there is CNS pathology, hypoxia, deficiencies, vitamin deficiencies. Sodium deficiency is also common because some of the drugs patients take cause a hyponatremia, right? So those also cause delirium. Endocrinopathies, acute vascular events, toxins and drugs, right, are also known to cause. So infection, metabolic states, you have to remember, they are very likely to go into delirium. So what you have to do is you have to find out a reason for delirium. People don't just go into delirium. We have to find the reason and treat the cause of delirium. Treat it early and robustly so that we can prevent the delirium progressing, or maybe even prevent delirium from occurring. in certain people. That's why the suspicion I mentioned early on. When someone is delirious, some of the differential diagnosis people refer to as querying whether they are demented. So dementia and delirium can happen at the same time. So delirium can be superimposed on someone with dementia. Okay, so that you have to understand. You have to suspect someone, as I mentioned before, someone comes with dementia. Someone who has dementia comes with some other problem, maybe chest infection or whatever. They're very likely to become delirious. Right, so robust treatment of the infection has to be done. Then because of the paranoia, we begin to think, people think, is this schizophrenia we're dealing with, or depression, or it could be anxiety, right? So these are all differential diagnoses you have to consider. So next we come to management. Now, initially we said, we were talking about the causes and all that. Management, there are key things. One is prevention. We must try to prevent people going into delirium. Right? So suspicion of delirium has to be there. Next, we have to find a cause of the delirium and treat the cause. If it's an infection or endocrinopathy or whatever metabolic issue, you have to treat that, and then the delirium resolves. So there is non-pharmacological management, which is very important, and pharmacological management, and what we do post-discharge, which is also important. Okay, so prevention, identification and treatment, modifying environmental factors, pharmacological factors, and post-discharge. So prevention means you have to suspect, and also that someone may be having delirium, and also the higher chance of the person going into delirium. So one way of doing it is, in someone who's older, we have to assess for sleep. Are they sleeping well in the night? Or are they sleeping during the day and not sleeping at night? Are they up the whole night? Which means we have to treat that, or that they are going into delirium. So that's a sign we have. And of course, orienting them. Now, obviously, the people who are older have, most of them, there are changes in the brain. So new place with whatever is happening in them, they might get disoriented. But before they get disoriented, we have to keep reorientating them. That is, tell them, okay, you're at this ward in this hospital. The time is this, today's date is this, today's day is this. Right? So it's important to do that, to prevent. Now, especially in people who had episodes of delirium, it's good to keep someone, a bystander, a known person with them, so that they feel safe in this environment. Next is assessment. Do a quick cognitive assessment. That is like whether their orientation, 1 minute, someone said a message. Orientation be done, whether they're oriented to time, place, person. Initially, it's the time that goes off. So orientation, sorry, does someone want to say something? There's a bit of disturbance. Can Krishni switch off a microphone, please? Thanks. Cognitive assessment is a very brief one. You don't have to do a MMSE or a MOCA for that matter. Just the orientation, attention, concentration, and short-term memory is fine. Okay. And of course, active management is a must. whatever infection or whatever they come with, you have to manage actively to prevent them from going into delirium. So when it comes to non-pharmacological management, this part is very important. You have to educate the family about what is happening, because it could be the first time this is happening. Suddenly there is a change in this person. They brought to hospital who was somewhat calm. After the second day or third day, suddenly they are very delirious and they're very agitated. So it can actually unnerve the family members, right? They haven't seen this man or woman like this before. So tell them what is happening. Explain to them. And it's always good to involve a family member as a carer, because they're familiar with them. But of course, you have to educate the family member as to what is happening, and what they can also keep orienting them, the family. When you communicate with people who are delirious, your communication has to be very clear, very precise, short communication. No jargon has to be used, right? Because they can't really understand much, because they're confused, right? It's all very woolly there. When they come out of it, then there'll be someone, a very high functioning person too, will be very, very confused and won't be able to actually understand what you're saying. Once they come out of it, then it's fine. So communication has to be clear. And environment, what you have to do is, ideally, you have to take them to a single room, because a ward setting is very busy. There's a lot of disturbances. So you have to avoid such a place. Keep them in a separate room where there is less noise, but not too calm also, right? Where there is daylight coming in, all that. And you have to keep orientating them with day and time. What time it is, what date it is, have a calendar. It's also good to have, so you have to make the place a little more familiar. What you can do is actually keep a photograph of the family, so that it's something familiar for them. They'll be able to identify and they'll feel more comfortable. So that is why we also have we also like a family member as a carer. Now, it's not very practical all the time. Sometimes they might not be able to have a family member, a known person, to be with the person, right? And you have also to keep orientating them regarding their identification and identification of the others. Like, okay, this is your son, this is your daughter, the name, all those things have to be done. The staff, as much as possible, has to be consistent. Obviously, one staff member can't be there right throughout. Okay. So as much as possible, say, certain staff members have to be designated to look after this patient. And they have to keep orientating the patient, come and introduce themselves and so, show their ID card, and all those things have to be done. And also, most people, we have to prevent sensory deprivation. So they have to wear spectacles. If they wear spectacles, ensure that they have it. Just because they're in hospital, don't take it away. Ensure they have it, because then it's easier for them. If they have hearing aids, give it to them. Walking aids, ensure they have, because they're more likely to fall, right? So again, continuing to environmental factors. So you have to avoid extreme sensory issues, right? So you can't overstimulate them, keep talking to them, put loud music like that, or understimulation. It has to be the correct amount. So that's why the ward is good, not good, because there's a lot of things happening. But on the other hand, a room alone with not much stimulation, no one around, with nothing to see, again, won't be good for them. Give them adequate space and ensure sleep. Sleep is very important, right? So don't keep waking them up in the middle of the night or when they're asleep in the night. Ideally, a single room. And even in the night, it's good to have controlled lighting. Have a dim light there. So even if they get up, they are a little oriented. Ensure they walk. Patients who are able to walk, who are ambulatory before, and say if they if it's okay for them to walk, ensure that they walk. Otherwise, that becomes a problem. And of course, we must try and use restriction as much as possible. Okay, so that is very important. It's very easy for us to tie the patient to a bed, but no, that becomes even more difficult for them. Okay, so restraining has to be the last resort. All right, we try all these things, try to manage without restraining a patient. So we do all these things, still they might be agitated. So what do? We have to use a bit of medication, chemicals to help calm them, because otherwise they could be a danger to themselves and to others also, right? Sometimes you get them in their delirious state jumping out of windows. We don't want that to happen. We must be very cautious about the amount of medication we use. So haloperidol is good because it doesn't really sedate them. We have to remember that most people going into delirium are elderly. So small doses of haloperidol. So as much as possible, use orally. So roughly 0.75 to 1.5 BD is good. More than 3 milligrams a day is likely to cause extrapyramidal symptoms, right? You don't want this elderly patient who's delirious to suddenly have a dystonic reaction. So small doses and space it out and give regular doses. You have to be cautious about the amount you give. The best evidence is haloperidol and quetiapine. Quetiapine is also available. So 12.5 to 25 milligrams BD, you can go up to about 200 milligrams a day. But use minimum doses as possible. That is key in managing delirium. Right? Again, with quetiapine, you have to be a little careful because it can cause sedation. If they're having sleep problems, 12.5 of quetiapine is good for them. Or else a small dose of promethazine, like 12.5, is also okay. Principles behind pharmacological management is one drug at a time. Don't give 2-3 drugs. Try to avoid benzodiazepines as much as possible because they have paradoxical effects on the elderly, especially. Give regular small doses. And you titrate according to the response. So don't just give, if the patient is mildly agitated, don't give 3 milligrams in one go. Avoid using IM, you have IM haloperidol as much as possible and try to use orally. And of course, you have to keep reviewing the patient about the medication and whether the patient is deteriorating or what, right? So that's pharmacological management. Post-discharge, families and carers have to be given advice and support. So what you tell them is, it is likely that this thing could happen again. So in which case, when the patient needs to get help, seek admission to hospital, you inform them, the admitting officer, about this, or when you go see a doctor, inform them so that you try and manage them accordingly. Now, something you have also to tell the family is, these symptoms of delirium might last longer than the underlying condition. Infection might settle, but there'll be small telltale signs of delirium. Not as bad as before, because then they won't be admitted to hospital. They won't be sent home. But there'll be a few things, like the attention might not be all that much. Things like that can happen. When you see them in hospital again, you should be doing a mini mental state examination. Because as I mentioned before, about 60% of them get cognitive impairment subsequently. So at 6 months, it's important that you do an MMSE, right? So that's about delirium. What you have to remember is suspect delirium. Try to prevent people from going into delirium. So early identification and treatment of delirium is important. And as much as possible, use non-pharmacological methods. If needed, well, you have to use the pharmacological methods. And reassess for support the family, because the family can be in distress. Post-discharge, also review them again, right? I'm also supposed to do a little bit on presentations of organic illnesses. Now, psychosis, depression, mania, anxiety, people will come with organic causes for these things, right? So just because someone is psychotic, maybe having auditory hallucinations or just visual hallucinations, don't think this is pure psychiatric and immediately do a referral to the psychiatrist. No, you have to exclude an organic cause. Even if the patient has been on treatment, say for depression, don't think it's this is a pure depression, there can't be an underlying organic cause. So it will send to the psychiatrist and reduce the number of patients on our ward. No, think. Some of the presentations are with psychosis is epilepsy. Pre-ictal, ictal, post-ictal, especially in temporal lobe epilepsy, you can have psychosis, right? People after head injury, encephalitis presentation might be with psychosis. Hypo and hyperglycemic states also can present like that, as well as uremia, right? So depression also can present with people after CVAs are very likely to get depressed. So you have to look out for that. Again, people with epilepsy. Hypothyroidism is a common thing, as well as cancers and alcohol. People who use alcohol might be depressed actually, right? Look out for a depression. Some people might present with mania because of steroids. Again, antidepressants, some people on antidepressants might have a switch and become manic. INH, which is given for treatment of TB, is known to cause mania, and of course, substances. Again, presentation of anxiety, epilepsy could be a presentation of anxiety. People with angina, MVPs might have. People using alcohol, benzodiazepines, because benzodiazepines, they get used to them, they get tolerant. So when the dose is not increased, then they may present with anxiety. All right, so what I want to tell you is, just because the presentation is like a depression or mania, psychosis, don't think this is functional. All the time it's functional. It could have an organic cause. So look out for it and look out for those things and then refer to the psychiatrist if needed. Okay, do you have any questions? That's all I have for you. Do you have any questions for me? Do you want to clarify anything? Anything to clarify? Or so what we want you to do is, especially when it comes to delirium, early diagnosis and management. Just because they get agitated, you don't have to refer to the psychiatrist unless you just can't manage. We want you to manage the patient. Any questions? Okay, in the absence of any questions, I'll stop here then. Thank you very much.
Thank you very much, Madam. On behalf of the Ministry of Health and Sri Lanka College of Psychiatrists, we are very grateful for your very informative lecture. If there are any questions, you can also put it on the chat box. If you don't feel comfortable speaking up because there's quite a bit of a crowd. If there are no questions, we can move on to the next session. Thank you, Madam, again. So the next session will be conducted by Dr. Gihan Abeyewardena, Consultant Psychiatrist at National Hospital, Kandy. He is the past president of the Sri Lanka College of Psychiatrists. And so we'll be speaking on suicidal risk assessment.
Morning, Dulangi. Hope you can see me and see my slides.
Yes, you haven't put it in the presentation mode though.
Oh. Shall I try again?
Yes, please.
Is it still the same or?
Yes, sir. We are still getting the other mode. If you just press on that icon to go into presentation mode, I think it should be okay.
So you might need to, all right.
Yes, yes, it's okay now.
All right now?
Yes, yes.
All right then. Good morning. Thank you for giving me this opportunity. I should thank the Ministry of Health as well as the Sri Lanka College of Psychiatrists and Dulangi, Dr. Dulangi Dahanayaka specifically for organizing this. I was given the topic of suicide and suicidal risk assessment. I think all medical officers, house officers, and even other specialists should have the basic skill of doing a suicide risk assessment, as this is one of the most important areas, and psychiatrists are not the first people who will come across with suicidal attempts. It will be mainly the emergency treatment units or the accident and emergency sections of the hospitals, the medical wards, and the surgical wards. So most of you all who are going to do your internship in medicine or surgery, sometimes even in gynecology and pediatrics, will come across suicidal attempts, and you should have the basic skill to assess the suicidal risk and actually see what you can do about it and what you should be doing, because not all suicidal attempts are being referred to a psychiatrist, although it's the ideal to do all the referrals, but sometimes in our system, in the Sri Lankan setup, sometimes it may be not practical. Okay, so please do ask me any questions in the middle. You can raise your hand and ask questions and unmute your mics, or as Dr. Dulangi Dahanayaka says, you can send some questions in the chat box as well. Okay, so as you know, suicide is an act with a fatal outcome. Now, there are two things, terms that you should be quite familiar with. The difference between suicide and deliberate self-harm, DSH. Now, what we see mainly in hospitals is deliberate self-harm, that sometimes they harm themselves, not with the intention of dying. It may be just to, out of frustration, cry for help, or to seek attention. All those harming yourself for that kind of, with that kind of intentions are called DSH or deliberate self-harm. But a suicide, as you know, is an act with a fatal outcome that is deliberately done with the help, with the knowledge that, or the expectation that it will end up with a fatal outcome. But sometimes, fortunately, it may not end up with a fatal outcome, and that's how they end up in hospitals. So most suicidal attempts are planned, and the most important thing is that in most cases a warning sign is being given, and sometimes they take precautions against discovery as well. So this is the time that we want, this is the area that we want our medical officers or the primary healthcare staff members to be quite vigilant about. So as you know, you may be already knowing this, it's the second most common cause of death among men in the most productive age group. And about 1 million people commit suicide each year, and about 15 times more people, 15 million people attempt suicide each year. And as you know, it's quite high in the social classes, the two extreme social classes, the lowest or the unskilled workers, followed by professionals. Okay, so 3 times more men attempt suicide, do commit suicide than women, but 3 times more women than men actually attempt committing suicide. So we have seen high rates among unemployed and the prisoners, and quite high rates in doctors and farmers. So among the doctors, can you tell us what kind of specialists do actually commit suicide more than the others? Any idea? So among the specialists, so yeah, probably you may be already knowing this. Anesthetists have a high rate of suicide, mainly because they have access to lethal methods. They know how to do it smartly. And they are also under severe stress, because you may think that they are just putting patients to rest or sleep, but then it's not as easy as that, and getting them up is quite a difficult one and a quite responsible task, and as well as they are more involved with critical care and emergency or the intensive care units as well. So there are certain other specialists also, not only anesthetists. Okay, so this is quite a disturbing slide. This is quite an old slide. 2002, now suicide rates in the world are calculated, measured, not in a percentage, but 1 in 100,000. So how many people in 100,000 population do commit suicide? If it's more than 13, it's considered a high rate. So Sri Lanka outstands as the only country in the Southeast Asian region with a high suicidal rate, and this is 2008. The colors have changed, but we are still the worst country in Southeast Asia with a high suicide rate. And the African states in 2008 have not had data, so that's why it's in gray color. But now in 2015, things have changed. We have quite a lot of data about suicide rates in the world, and now India has become friends with us. And as Russia and China have always been friends with us with a high suicide rate, but now other countries, Australia, have improved, and the South American countries have a lesser rate, and most of the African countries are better than us. So it's really disgusting to see these slides, because of our country being one of the countries in our region with the highest suicidal rates. So this is 2022. Again, not very good results. Yeah. So, but one good thing is that our suicide rate is declining. Now you can see from 2000 to 2016, it has been not drastically, but gradually the suicide rate has been declining. The topmost one says the total, and the middle one, the male, and the lowest, the female suicide rate. Okay, so that is something that we can be happy about. And so this is a very interesting slide of the impact of, now this was done, impact of pesticide regulations on suicide in Sri Lanka by Professor Ravindra Fernando and Professor Gunnell in January 2008. Now you can see the blue line is where we have the suicide rate in Sri Lanka following self-poisoning with pesticides and weedicides. So now this was the main method in Sri Lanka for quite some time, and it came after year 1996. You can see, according to this graph, there's a drastic decline in the death rate of suicide in Sri Lanka from pesticide poisoning. So this was mainly due to the fact that in 1996, there was a president in Sri Lanka who took this high suicide rate in Sri Lanka very seriously. And this was the only president who appointed a special presidential task force to combat not terrorism, but suicide in the country. So this was President Chandrika Kumartunga, where so many psychiatrists and physicians from Peradeniya and Colombo medical faculties and the Ministry of Health, they were appointed to this expert panel, and they recommended that certain pesticides should be banned, like parathion and methyl parathion, and then several pesticides the lethality were reduced. The content was changed in certain pesticides. So this, and then there were strict regulations about sale of pesticides to minors. So this has brought in a drastic decline, which is good. But unfortunately, the lower dark blue line, the hanging rate in Sri Lanka is going up. The others are quite constant. Okay, so this is, we already talked about, and the causes. Why do people commit suicide? It may be psychiatric or medical factors, social factors, biological factors, and certain psychological factors also. So psychiatric or medical causes of suicide is very important that you all know this. About 90% of those who die of suicide have some form of psychiatric disorder at the time of death. So this was an old 1974 finding, which is still applicable. And out of this, about 1/3 to half commit suicide because of personality disorders, about 15% due to mood disorders, schizophrenia, and psychotic disorders, about 7%, alcohol, 7%. Now, when mood disorders, depression and alcohol get together, the risk goes up to about 25%. So this is another slide about this is not Sri Lankan data, but so according to the psychiatric diagnosis, what kind of people actually do commit suicide? About 35% due to mood disorders, 22% substance-related disorders, and about 10% schizophrenia. Okay, so there are certain social factors as well, and we won't go through all of them. But I would like to concentrate more on the last statement. The media coverage of suicide. Now, this is a huge problem in Sri Lanka. Now, you may have got to know that there had been already 4 suicides in the Peradeniya University, and 3 students in the final year engineering faculty have committed suicide, and 1 very recently, student, 4th year psychology student of the arts faculty committed suicide. And unfortunately, this was given wide coverage, and these suicides were sensationalized, glamorized in our public media as well as social media. Not much in social media, but mainly in public media. So this is very unfortunate because all the details are being given, the privacy of the confidentiality of the people who have committed suicides are violated, and all the details about their parents, and they go to the extent of assuming things and saying that this person committed suicide because of this, which is not the case all the time. And unnecessary details about the methods of them how they committed suicide and why they committed suicide. All the personal details are being published or broadcast over public media, TV, radio, as well as the print media. So this can lead to a trend, a fashion of committing suicide, and we have seen such a lot of copycat suicides. Now, when this psychology student committed suicide in Peradeniya University, there were 3 unfortunate attempts of suicide in the arts faculty following that. So, which is very bad, which is very irresponsible media coverage of these suicides, which doesn't happen in other countries. So it has been very well clearly shown that irresponsible media coverage of suicide can lead to copycat suicides and a development of trend of committing suicide. So that is something that I think the Sri Lanka College of Psychiatrists took this very seriously quite some time ago, and conducted a workshop for journalists in Sri Lanka and printed a booklet about media ethics on reporting of suicide. But as you know, unfortunately, things don't last in Sri Lanka for a long time. So it was there only for about 2-3 weeks, and then they started doing it again. With all that, so I think the College of Psychiatrists probably will have to take it up again about media coverage of suicide. So there's a very strong association between impulsivity and aggression, and the serotonin levels going low in the people who commit suicide, and of course the genetic factors. Yes, so these are the protective factors: strong family history. I should change this slide. Pregnancy is not anymore considered a protective factor. I'm sorry about that. This was the earlier teaching or the understanding, but now pregnancy is not considered a protective factor anymore. So having dependent children, strong religious beliefs, and this is a slide again that Sri Lanka should be ashamed about. Suicide rates according to religion. Atheists who don't believe in any religion have a high suicide rate. The total suicide rate is with orange color, followed by Buddhists who have a high suicide rate, Christians, then third or fourth, Hindus, and the best results are from the Islamic faith. The Muslims, 0% of committing suicide, which is great. And risk factors for suicide. The easiest way to remember is white old males have a high risk of committing suicide. Widows, ones with poor health, lack of social support, antisocial personality traits, and very importantly, the last one, history of childhood sexual abuse. Odds of a sexually abused patient attempting suicide is 10 times more than a non-sexually abused person. So all these people who do actually attempt suicide, when they come to your wards, always make it a point to ask about history of sexual abuse, and specifically history of childhood sexual abuse, where you should address this and refer to us if there's one that has not been addressed, which has been suppressed for years, and whether this was the reason for this suicidal attempt. Okay, and this is very important, the presence of a psychiatric disorder and a previous history of suicide. These are the best predictors of a future suicidal attempt or suicide. So just remember that the best predictor of future violence is previous violence. We all know about it. The same principle applies to suicide. So people who have attempted suicide in the past are more prone to attempt it again, or more likely to do it again. And if that person has a history of a psychiatric disorder, then the risk is doubled. And so always in your patients who have attempted suicide, look for a past history of suicidal attempt and past history of getting treated for psychiatric disorder or having a psychiatric disorder without being treated. Then it's high risk, and this is a type of patient that you should be referring to psychiatrist. And the greatest risk, again, for house officers, and especially in medical wards, surgical wards, during the first week after hospital admission, because they are not treated, and it will take time for our medications to kick in or interventions to give results. First week after, so within hospitals, within wards, during the first week of hospital admission, the suicide rate is quite high, and you have to be vigilant and make sure that you instruct the nurses to be vigilant about them and give them a front bed where they can be observed, and be vigilant where they are going, and if there are any suicidal means in the ward. And the month immediately after discharge from hospital, also the risk is high. Okay, so this is a slide from Sri Lanka. Again, the method of suicide is changing in Sri Lanka. This is the blue line, says the pesticide or the weedicide and insecticide poisoning, which was quite high in the years from 1960 to 1996, and now it's gradually coming down. But unfortunately, in the graphs that are in the illustrations shown below, 80% in 1995 of Sri Lankans who committed suicide had done that with pesticide poisoning, but now it has changed to 52% with hanging. So hanging is up on the rise. And pesticide has come down to 29% in 2016. Okay, so as you know, we recorded a very high suicide rate. The highest rate in the world in 1996, it was 46 out of 100,000 people in Sri Lanka committed suicide. And but fortunately, we have got rid of that world record. So now we are, I think, 4th in the list, or even lower. And in 1980, we set another record as the highest female suicide rate in the world. Unfortunately, this is the only world record that we still hold on to, and Sri Lanka remains the country with the highest female suicide rate to date, unfortunately. And this is a slide from 2008, where they say the female suicide rates in the world, Sri Lanka has 16.8. This is from the WHO. Okay, so the causes of suicide in Sri Lanka, it's mainly the socio-cultural factors, poverty, unemployment, social deprivation. But unfortunately, quite a percentage of our people do actually commit suicide when they are wanting to do it as a cry for help, not wanting to die, but just out of frustration. But unfortunately, they may end up dying. And when they have states of learned helplessness, when they can't escape from an intolerable situation, they may resort to committing suicide and attempting to influence others. Sri Lankans probably in general have a very low value for life, unfortunately, and we have come into got desensitized with social media, or not social media, sorry, the culture or the novels that we read, the films that we see, and what we hear from our small days, that have socially learned of suicide as a mean to solve our problem. So this is there was a ban of showing people committing suicide in films, teledramas, and sometimes in novels also, but unfortunately these things have not been implemented later on. And then about fictional reporting of suicides by public media, which I already mentioned about. And the most important part of my lecture is about how to assess the suicidal risk. Okay, so this is the most important thing, that you have to master the skill as house officers, intern medical officers, and later on as junior doctors or even senior specialists. Because not all of you will become psychiatrists, and only a very few of you will become psychiatrists, and the others will go into other specialties. But as physicians, surgeons, pediatricians, and even sometimes gynecologists, and specifically emergency medicine specialists and the intensivists. You have to have the skill of, in about 5 to 10 minutes, assess the suicide risk when a patient comes to you after attempting suicide. So sad person suicide scale is one that is not being used in hospitals. It's mainly used in primary healthcare settings or in the community, which is not a very good rating scale for assessing suicide risk, but it's okay. It's a crude one, but it's still acceptable. It's been used. But the most important thing that I have to highlight or concentrate on is the Beck suicidal intent scale, which has been used in all the hospitals all over the world after a suicidal attempt, which I will go through now. So sad persons, I will quickly go through that. It's just you write sad persons, and for each letter, there's some, if you can remember, for sex, if it's a male sex, 3 times more chance of committing suicide, you give 1 point. Ages lower than 19 years or more than 45, you give 1 point. If they are depressed, 1 point. P means if there's a previous attempt. Ethanol abuse, you give 1 point each. And rational thinking loss. Now this is why I say that this is not a very good rating scale, because D, depression, and R, rational thinking loss, are very difficult things to assess by a non-psychiatrist. So whether you are depressed or not, it's difficult in a few minutes. And R, whether they have rational thinking loss, means whether they are having any irrational thinking with delusions and hallucinations. Again, it's difficult to detect in the primary healthcare settings. But that's why it's a bit not practical. S means social support lacking. O, there's an organized plan. N, no spouse, and S, sickness. So as there are some few problems in this, they have modified this. Now this is called modified sad person scale, which is better. So again, the same letters stand, and for some they have given 2 points. For sex and age, it's the same. D, as this difficult in primary healthcare settings to detect depression, they have added hopelessness as well. So to ask whether the patients are hopeless, feeling hopeless. And P is the same. Previous suicidal attempt, they have added that if the patient is on psychiatric care. So again, that's a very important thing. E is ethanol. R is the same. Still, rational thinking loss remains the same. S, they have changed a bit, separated, divorced, or widowed. O is organized plan or attempt. N, no social supports. S, they have changed. From the previous one, it was sickness, chronic sickness like, let's say, epilepsy, Parkinson's, or asthma. But here it's they have taken it out completely. And S has been replaced with stated future intent, and they have given 2 points. So you ask these 10 questions, and if they score more than 5 out of 10, you strongly consider hospitalization, but immediately hospitalize, even against the will of the patient, or commit them to get hospitalized. And but below 5, you can follow them up, and if it's 1, 2, send them home with follow-up. So this is the more important one, the Beck suicidal intent scale. So now this is what all house officers, all junior and senior medical officers should be aware of. This is what is being used all over the world in hospital settings to assess a suicidal intention or intent after a suicidal attempt. Now the previous one, the sad persons, is to be used in the general community, and this considers alcohol abuse and previous attempts, having a previous psychiatric disorder. All that is being considered. So this gives an overall assessment of the suicide risk. But here, in this particular scale, you give a score only for that particular suicidal attempt. Okay, so if a person comes now, let's say 18-year-old teenage schoolgirl comes to your medical ward after taking 25 tablets of paracetamol. So you want to assess what to do now. Should I send the patient home? Should I send the patient home and ask her to go to a psychiatric clinic? or should I immediately refer her to a psychiatrist because of the high suicidal intention? So to come to that assessment, you have to give a score, asking these 10 questions, which are quite easy, which can be done in about 7 to 10 minutes, and which will give you an idea what to do. So if you write in your referral to the psychiatrist that the Beck's suicidal intent score is this, then we have a very clear objective idea about where we stand and what we do, and it will be a very good practical way of doing this. So the problems in this scale is that this is not going to consider the previous psychiatric history or ethanol abuse or alcohol or drug abuse, and having a family history of suicide. All those are not considered here. Here we give a mark, objective mark, only for the this particular suicidal attempt. On that particular attempt, how serious was the suicidal ideation? Okay, so we divide the suicidal act into 3 parts: before the act per se, and after the act. Okay, so before the act, what do people do? Now let's take the same example of taking 18-year-old girl taking 25 tablets of paracetamol. What she has done before taking the tablets, whether she has planned this in advance, whether she had gone to several pharmacies and collected these tablets, and whether she left a suicidal note. Now, it doesn't have to be a piece of paper or written in pen. It's any expression of suicide is taken as a suicidal note. It can be a Twitter message or Facebook message or whatever, SMS, or some people telling their mothers or boyfriends or whoever that I'm going to kill myself is considered a suicidal note as well. It doesn't have to be a piece of paper. And the third one, whether they have done the final acts before committing suicide, like settling their loans or writing a last will, distributing their assets, properties, or whatever in preparation of committing suicide. Okay, so 3 questions before the act: whether they have planned it in advance, how did they collect the 25 tablets of paracetamol, whether they have expressed suicidal ideation and written a note, whether they have done any final acts before committing suicide. Okay, and then we come to the second part, where we talk about circumstances around, or the act per se, whether the patient was alone at the time that she took the paracetamol. So she has selected a time when nobody is at home, so she was all alone. And the second one, interventions were unlikely. So she selected the time where interventions would be unlikely, so that she will be detected or discovered. So let's see that this particular girl, her both parents are teachers who have gone to school to teach, and the brother also has gone to school, so they will come home only at about, let's say, 2 o'clock, 2:30. So she selects a time around 11 o'clock so that nobody will be there, so they will not find. And the third one, again, there's a bit of overlap between the second and third, whether she has taken active precautions against discovery, whether she was smart enough to switch off her mobile phone or take the land phone away, lock herself, or go to some, now let's say if a patient is in Kandy, she will go to Anuradhapura and go to a forest and take weedicides, something like that. So they take all precautions against discovery so that nobody will find them after taking an overdose or taking weedicide, and that they will not be saved. So the third one is taking active precautions so that nobody will find them. Second one is taking passive things so that interventions when we will be unlikely to detect them. And the first one was being alone, that's over, so that nobody will see them doing this. So then we come to the third part, after the act. What do they do so that they will not be saved? So let's see this, the 18-year-old girl who took 25 tablets of paracetamol. She took it, and then the mother came at 2:30 after school, and then she started vomiting, and the mother asked, "Daughter, why are you vomiting? Is there any problem?" Then she'll say, no, don't worry. I'm just having a headache," and just lock herself again in the room and not seeking help. So then it's a high suicidal intention. You give 1 point there. And the second one that you ask after the act is, why did you take it? Now that's a very simple, rational, and a common sense question. Did you want to die, or did you want to attract the attention of your parents or your boyfriend, or was it a cry for help? Did you actually want to die? So if they really wanted to die, if they stated a wish to die, you give 1 point. And the third one, you ask, why did you select 25 tablets of paracetamol and not less or not more? Then they will say that I went on the internet and found that 20 tablets of paracetamol is the lethal dose. So I took 5 extra to be on the safe side. So I will kill myself. Then that means that she really knew that 25 tablets will kill her, and she wanted to kill herself, and that's why she took it. So she believed that would result in death, also gives her 1 point. And so if a pediatric patient says that I took 10 tablets of paracetamol and I thought that it will kill me, that also is taken as a mark, and you give 1 point because that boy actually believed that 10 tablets of paracetamol will kill him. So that's the belief that the patient has at the time of taking in the overdose. And the last question that you ask is whether the patient regrets the failure. Okay, so are you happy now that you have been saved, or would it have been better for you to die? And some people really curse the doctors and say that, why did you save me? I would have much better. I would have really liked to die. It would have been much better for me to be dead rather than be alive. So if they regret the failure, then you give 1 point there. Okay, so this is a very important, very, very interesting, or a very objective, way of assessing the suicide risk about one particular attempt. Now, the setbacks of this scale is that it will not give any marks for previous suicidal attempts, family history of suicide, the patient having a past psychiatric disorder, or substance misuse. Those are not regarded here, but this is very objective because it will give a score about that particular attempt that the patient came to hospital with, and you can decide for that attempt what kind of a suicidal intention was there. So accordingly, again, you give 5 points. Sorry, 1 point for each of these 10 questions. And if the patients score more than 5 out of 10, then it's very important that you refer to the psychiatrist. And if they score more than 5, like 6, 7, 8, 9, then you should not refer them to the psychiatric clinics, but immediately take a psychiatric opinion before you discharge. So it's better that you immediately do a psychiatric referral and say that this patient scores very high on the Beck suicidal intent scale, and psychiatric intervention is essential. Okay, so hope this is clear, because this is very important. So all house officers should take this into serious consideration and get used to this scale. You just ask 10 questions. Divide the particular act into 3 parts: before the act, after the act, and the act per se. And 3 questions before the act: have you planned it? Have you left a suicidal note? Have you told that you're going to commit suicide to anybody? Have you done any final acts? And the act, were you alone at the time? Was it unlikely that anybody will detect you? Did you take active precautions so that you will not be found by somebody? Then after the act, did you seek help after taking? Because if a girl says that she took 25 tablets of paracetamol and then immediately called the boyfriend and told, darling, take me to hospital by ambulance. So that is not a serious suicidal attempt. So was not seeking help. She wanted to die and believed the act would result in death, and now feels sad that she was saved by the hospital staff. So that is the Beck suicidal intent scale. And as house officers, as junior and senior medical officers, it's very important that you being non-judgmental, and when you see a patient after an attempt of suicide. So you should remember that patients go through emotional turmoil, and they have come to the stage where they have not wanted to live anymore. So you can see, you can imagine what kind of a mental state that the patient must have been in before coming to hospital. So they really are frustrated with life, and they are disgusted and feel like shit, and then they want to commit suicide. And then but fortunately it has not ended up in suicide, and then they end up in hospital. So as hospital staff, it's very important that you don't be, that you're not being judgmental and blaming the patient and seeing that, oh my God, aren't you so silly for trying to commit suicide for such a small thing? That kind of idiotic statement should not be given by hospital staff. And you should be very calm, and you should be kind to this patient and treat them as human beings. And this is what we see in medical wards and surgical wards quite frequently, that patients are being laughed at, patients are being humiliated, and patients are, they really think that it would have been much better for them to die rather than come into medical ward, because first they are being humiliated by the minor staff, then by the nurses, and then by the doctors for wasting their time and wasting a bed. They are really being ill-treated. So they will definitely go and commit suicide next time and not come to your wards. So that's very important, that you being not judgmental and just talking to them in a kind manner will solve most of their problems. And this is sometimes it's very difficult to assess whether they are feeling suicidal, because if you ask directly, are you having suicidal ideas, they will say no. But it's always better to be more subtle in your questioning. So this is why I have written as normalizing. When someone feels frustrated and upset, they may have thoughts that life just isn't worth living. So have you ever had thoughts that you just didn't want to go on? Rather than mentioning the word suicide, it's better to ask in a subtle manner. Now, people, when they undergo severe stress, sometimes they lose interest in everything that they have enjoyed in life, and they may come to the extent of even thinking that life is not worth living anymore. So have you had any thoughts of that sort, where you didn't want to go on with life? So that kind of thing is very a good way of asking that, and then you can nail him down to ask, okay, were you thinking of harming yourself, ending your life, and were you planning it? And then on a scale of 1 to 10, how strong is your desire to kill yourself? 0 being not having any desire at all, and 10 being having a serious suicidal plan and ideation. Where do you stand today? So that is, yeah, we'll not talk about so I will finish with that, the take-home message. So it's very important that you be empathetic to these patients, and as I told you earlier, non-judgmental towards the already frustrated, unfortunate patients who are in severe distress, who come to you in emotional turmoil, and they have come to a stage where they thought that life is not worth living anymore, and they have attempted suicide, and they have lost interest in everything in life, and they have come to hospital. So you may be the first person that is talking to this patient after such an attempt, and it's very important that you be kind to that patient, sit with him or her, and just give her or him some minutes, 5 to 10 minutes, just to talk and ask what really made you come to this decision, and we are here to help you so that you will not have this kind of frustration in the future. So, and sitting down with them and talking to them in detail, and assessing the suicidal risk and referring appropriately is what we expect from all the house officers and the junior medical officers. Okay, then, thank you very much. If you have any questions, I would be more than glad to answer you.
Thank you very much, sir. If there are any questions, please feel free to ask, or you can even put it in the chat function.
I saw in the chat box, they have, yeah, that is quite correct. They have written veterinary surgeons have a high suicidal rate, which is correct. Yes. So not only anesthetists, yes, veterinary surgeons also have a high suicide rate. Yes. Any other questions? If not, I have taken a bit more time, haven't I, Dulangi? So the next person
fine.
must be.
We started a little early. Prof. Madhubhashini is also here. I'm trying to make her a co-host, but I don't seem to be able to do that. We can ask Dr. Roshan to do that. Any questions or any?
Yeah. So now for house officers, we have tried this this Beck's introducing the Beck suicidal intent scales to medical wards, and in the hospitals that I worked in, I actually printed these forms and gave it to the SHOs, the HOs, and they started sending us for about 2-3 weeks, and it stopped. And when I asked them, they say that it's very time consuming. They are overloaded with work and they don't have time to fill another form. But if you actually do it, it takes about 5 to 10 minutes and that's it. And not even 10 minutes. So if you get the skill of it, the art, doing the art of it, it's quite a quick thing. And because what we see is sometimes unnecessarily there are referrals sent to psychiatric wards, but that is okay. But the most dangerous thing is that some patients with serious suicidal intentions are being missed and they are sent home and they are being told, okay, you come to the psychiatric clinic, and in the meantime they do commit suicide. So that is why it's very important that you have an idea about assessing suicidal risk and doing the referral appropriately. Okay, then shall I stop here?
Okay, sir. Thank you very much for that informative lecture, sir. So the next session will be done by Professor Madhubhashini Dayabandar. She is the head of the Department of Psychiatry at the Faculty of Medicine, Colombo, and a consultant psychiatrist at National Hospital, Colombo. She will be speaking to you on psychiatric illnesses during pregnancy and the postpartum period.
Hello, good morning, Tulangi, and good morning, everyone. Nice to be here. I'll just share my slides. Can you see my slides?
Yes. Yes, Prof. Madhavi.
And Tulangi, just confirm if you can see them progressing.
Yes.
Right, okay, thanks. So thank you for your kind introduction. At any time, I would be happy to answer any questions if you do have anything. And also, if you can send me anything on chat. I'm pretty sure this is a subject that you have learned in during your, psychiatry teaching. But let's approach this in a little bit different way, because all of you guys are now actually doctors, and very soon you will be the basically the big boss in the ward, because you know how it comes. The consultant is there, but you would be the person who is always there in the ward and always running here and there, and the person who is closest to the patient at a particular time. So therefore, you would be the first person that a patient would actually relate to. So it's important that you are the support person for anybody who has developed any psychiatric illness during the pregnancy period or in the postpartum period. So during this lecture, I will hope to go through some risk factors for psychiatric illness in the pregnancy and the postpartum periods, describe maternity blues, and then we'll go through postpartum psychosis, depression, and a little bit on the principles of treatment. First of all, let's go through this case history. This is a 28-year-old primie, and was referred from, let's say, the Castle Street Hospital to our unit on the second day postpartum. And the medical and the nursing staff were concerned that she was crying. She was very anxious. She did not sleep well the night before. And when you see her, she says, I feel rather confused, and she's very tearful. And she's saying, I'm not confident to look after my baby properly. I'm not used to this. My mother is also not there to help me. And I'm very confused as to what can I do. So take 1 minute. Let me know in chat what is the most likely diagnosis in this patient, and think about what is the required management. So just send me what is the most likely diagnosis, and we'll talk about the management as we go along. Okay. I've got some answers coming in. Great. Can I have a few more answers to see if you're thinking on your feet? Okay, I've got lots of answers, and they say almost everybody thinks it's maternity blues and or postpartum blues, and you're correct. Yes. So you have learned well, and one person has sent to me the answer adjustment disorder. Okay, really good that you sent me that answer, because we will actually have a little bit of a discussion on how to differentiate between adjustment disorder and maternity blues. So this is typically a mother who is having maternity blues. And we will go through the different presentations as we go along. Now, this might very well be your story, Many of you would have either got married by now or is expected to get, settled down by the end of internship. Some of you might get pregnant during internship, might have babies immediately after internship, after some time. Some of you might become fathers, some of you might become mothers. And, this is a common story. And it might be yours because, to tell you the truth, I actually delivered in the very same ward that I worked in as an intern house officer in the Gyn and Obs unit. And as usual, what happens with all medical staff, developed complications, the baby was in PBU and blah, blah, blah. It was a long story. So I know how it is important, how important it is that to have a little bit of support for a mother, because I was in that situation. And only when I was in the situation, I realized as an intern, I could have done more for some of these mothers. I don't think I was a bad doctor, but, I definitely could have done a little bit more to help support these young mothers, or even, mothers in different stages of pregnancy and postpartum, and from different social backgrounds and different, ages and all. So it's not an easy time. Pregnancy and postpartum period is not an easy time. It's a very new experience for especially a primary mother. Even if it's a, maybe second or third pregnancy, of course, what is happening, but each experience can be different because the babies are different, they have different temperaments, the situation is different, like that. Then it's a painful thing, and there's a lot of pain, even if you deliver by cesarean section or by by normal delivery, there is a lot of pain involved. So even though the joy of delivering and having a new life in your hand is there, the mother is still having pain, and so you need to be a little bit sensitive to that. And these postpartum mothers, now we are all during internship, I was really used to getting some sleep at least. And after you deliver a baby, the rest of your life is going to be very different for the next 2 to 3 years. you hardly get any sleep in the night. And in the very first few weeks, you realize, you have to get up so many times in the night and your sleep is broken. And some of the young mothers, they have difficulty in establishing breastfeeding. And, there would be a lot of interference by relatives, neighbors, in-laws, extended family, giving them various advices. That's the thing which happens in Sri Lanka. They will come and tell you, look, you don't have breast milk. And the reason is that you are not eating enough dil and kos and all these kinds of food. And they urge you to eat that, bring you food and all that. And it's a lot of stress to take in so many different opinions. And of course, if the baby is ill, then again, the new parents would be at so much stress, and particularly the mother. So it's not an easy time. And when you go through this experience, you will realize how difficult it is. And as the intern doctor who is there in the ward, you are the best person to, understand the situation of this young mother and help her go through this. A kind word will go a long way. What are the risk factors for developing psychiatric illness in the pregnancy and postpartum periods? It's important to know these because from the antenatal clinic itself, you can identify and you can refer them for appropriate support. So maybe the Mithrupias are in your hospital. So I know that Disorder Maternity Hospital has a special service for females who are experiencing domestic violence. There are Mithrupias all over the country. The nearest one to me is in the Family Health Bureau, with which we work very closely. And refer to a psychiatry unit in the hospital, refer to some social services if possible. So identify them as early as possible. So who are at high risk for developing psychiatric illness? If the pregnancy is particularly unwanted, there is a lot of now social issues which are going to come up if during the pregnancy and afterwards. If the mother has a past history of psychiatric disorder, we know mother is at high risk of developing the same kind of illness during pregnancy and postpartum period. Some time ago, we tended to believe that pregnancy was actually a protective factor for developing psychiatric illness. And now we know that it is not so. And, they still have a high risk of some illnesses. And if they have a past history of psychiatric disorder, then they are at higher risk of coming down with the same illness during pregnancy period and more so during the postpartum period. So the risk is higher in the postpartum period when compared to the pregnancy period, and pregnancy period higher when compared to somebody who might not be pregnant. If there's a family history of mental illness, particularly ask if the young mothers, mother or their sisters have actually suffered from postpartum onset psychiatric illness. And what we usually ask them in Sinhalese is, me වැදුගේ සන්නිය වගේ හැදිලා තියෙනවද අම්මට හරි ඔයාගේ අක්කලා කාට හරි කියලා ඉවර වෙලා. We usually ask, and I know the Tamil word is also sunny. So even though I might not be correct. So just ask them. And if they have, then we know the person might be particularly at high risk of developing postpartum episodes. Medical comorbidities, if they have PIH, if they have gestational diabetes, if they have other medical comorbidities, we know they are at high risk. Now, this particular problem coming up very frequently in antenatal care now is substance use in the mother. So if you detect substance use in the mother, and that is going to actually complicate things a whole lot more, and identifying these mothers early in the antenatal period is really, really important, even though most of these mothers would actually come and present to the clinic rather late, or else they might actually come only for the delivery. Check if you find that, this mother might actually be using substances, look for pointers, look for evidence of self-harm on the forearms, look for injection tracks, ask the mother directly, is your partner using substances? Is the partner using heroin, ice, cannabis? And then if they say yes, then ask, look, have you also tried these substances? Have you been using? And these mothers are very often rather unreliable in attending antenatal clinics. The baby might be having intrauterine growth retardation. So these sort of mothers, directly ask them if they are using substances. And if you're not, challenging or confronting, the patient would actually reveal it to you readily without any problem. Most often what happens is in and postnatal units, they have conflicts with the postnatal unit, but when they are referred here and you talk to them and tell, look, we are not trying to, persecute you or, find fault with you, but we need to help you and the baby's life is also at risk. Therefore, just tell us if you're using any substances so that we can manage it appropriately. Then these mothers and the partners would usually come out with substance use. Mothers coming from very poor socioeconomic background with poverty, other social issues, and particularly domestic violence, again, we know are at high risk of developing psychiatric illness in the pregnancy and the postpartum period. So, why is it that we worry about mental illness in pregnancy and postpartum period? It's not only because it affects the mother. Of course, it has lots of effects on the mother, like, suicidal risk and, difficulties in management and all that. But we know that it significantly affects the fetus and the newborn child and in a lot of years to come. So it will affect fetal growth, it will affect cognitive and emotional development of the child. And if we need to give a lot of medicines during the pregnancy period before the mother delivers, then we know some of the medications that we might use can cause teratogenicity. So it is always best to identify the mothers at risk and try to prevent them coming and down with a psychiatric illness, rather than having to use large doses of medications and having problems later with the baby after delivery. So the principle here is to detect early and support them intensively and prevent complications later during the postpartum period. Right. I want to talk 2 minutes on stillbirth. So you know that probably it might be a pregnancy that they had looked forward to very much. It might be a precious child. And this is a great loss to both the mother and the husband. It's very important that you handle a stillbirth very carefully and sensitively. And I'll tell you a story during my internship period, which I later felt I should have handled and I should have handled better. One of, again, a regret that, during the internship period. So I was delivering. I delivered a very fresh intrauterine death. And the mother knew that the child has now passed away. And, we delivered the child and I attended to the mother. And then I was actually, I think, doing something else in the delivery room. The baby was a beautiful child with, however, both the limbs had not formed. So there was agenesis of the limbs. But, with a very nice angelic face. And I really remember the child. And, without any warning whatsoever, the nurse, because after having seen the child, it's important that the parents know that the child suffered some, had some malformations and they can, undergo genetic screening and all that. And one of the policies is that they, if there is something they need to know and, they might actually see how the child looks. But the nurse actually suddenly gave the child to the mother and said, your child is not properly formed. And the mother shrieked and shouted, and the pain and the insensitivity of that action affected me for a long, long time to come. I know now how we should have affected. I was, terribly upset at that time that happened. What we should have done is we should have delivered the child. We should have just kept the child aside and told the mother, look, you already knew that, the child was not going to be alive. At that time, we are really sorry. Comforted her a little bit and said, do you want to hold the child? It looks, if you want to hold the child, do you want to have a look? The baby is really, it's a lovely baby, but, some of the things are missing, and, it might really affect you. Do you want to see the child or not? If you don't want to see now, we can arrange for you to see later. And I'm pretty sure the mother would have said, yes, I want to have a look at the child. And, we could have nicely given to the child, nicely wrapped up. And, very slowly the mother could have, opened and seen the baby. So ask if they want to see the child and be very sensitive about it. And, very often, maybe sometimes the baby might be macerated and the mother might not want to see the child at all, but the baby at all. And the other thing is, ask them if they want to have a proper funeral. Ask the parents, both the father and the mother, if they want to go ahead with a proper funeral. And I think you should encourage them to have a proper funeral and say goodbye, so that it helps them to go through this bereavement process. Okay. The next one, the case that we discussed, maternity blues. And it will surprise you to, probably, of course, now you know your psychiatry, that, almost 2/3 of postpartum mothers will actually develop maternity blues. And the characteristic features are that they have mood swings. You remember that mother whom we talked about as the small case history. So, the mood is going up and down very frequently. They can't, identify what is happening. The mood is going up and down. I am confused, crying. At other times, I feel happy. I feel sometimes a little bit angry. This feeling of confusion and anxiety is something that they typically complain of, rather than feeling sad or, feeling euphoric, as in mania. The onset is very early, so you might actually see it the very second day after delivery, and it usually peaks in the 3rd or 4th days, and it completely resolves within a few days' time, and it hardly goes beyond the first week. So that's how you are going to differentiate it from a postpartum psychosis or a depression, which is of later onset, and it would actually be pervasive, and it would not usually spontaneously resolve. What the treatment is basically for maternity blues, help them to get some sleep. Ask the ward staff to, get some sleep. If the baby is crying, to be vigilant about it and give the mother some support to feed in the night. Sometimes I've seen really good interns who have, asked their consultant to allow the mother to have, some sort of support, maybe the mother's mother or, somebody else, another female, to stay with them in the ward for a few days if they need to stay. Give them reassurance. Look, it sounds like, you are just having something we call maternity blues, and it's normal because you can give some explanation. It's due to the ups and downs in your hormonal levels, and therefore, it will go away, but we will just keep an eye on you and see how things go. If they have difficulty with sleeping, if they feel anxious, you might actually use a small dose of chlormethazine or chlorpromazine to help them with sleep and with anxiety. And that's all they might actually need. You can use a very small dose of olanzapine also, like 2.5 milligrams, to just help them calm down. But I would actually prefer either promethazine or a little bit of chlorpromazine, maybe 25 to 50 milligrams. That's all. So they usually get better with a little bit of support and reassurance. Now, how about postpartum psychosis? It's rare when compared to maternity blues. It's 1 in 500 live births, and the mother would usually have a past history or a family history of mental illness, and they are usually preemies, and they might actually, these risk factors might be there. And the onset is after the first few days, within the first few weeks, actually. And they might actually present with insomnia, overactivity. But again, in postpartum psychiatric illness, you don't really see the characteristic mood changes. So you might actually not see the really characteristic depressed mood. You might actually see a little bit more, they might talk of, a lot of sad thoughts and worthlessness, all that, but the mood might actually just similar to maternity blues, but not like that, but very pervasively, the mood might be low, but they might also have some anxiety and, feeling some perplexity or confusion. And of course, in psychosis, you will see delusions, you will see hallucinations, and the mood symptoms might be depressive or manic type, and sometimes they might also be of mixed. And we know that postpartum psychosis is very likely to develop into bipolar affective disorder later in life, even though some of these mothers might never have another episode again in their life. So the important thing in postpartum psychosis is that you need to exclude the risks. If the mother is depressed, you have to exclude the risk of suicide. And of course, here is another life involved. Are there any risks to the baby? Now, don't be afraid of asking the mother if there is any risk to the baby. A very sensitive way of handling this question is going on a, sort of a step ladder pattern, where you simply ask, okay, how do you, feel about the baby? What do you think about the baby? Are you happy about the baby? What do you want to do about the baby? Are you afraid that you might have any difficulties managing the baby? Do you worry that, something might be wrong with the baby? If so, what is wrong? Do you think it is serious? And then, you can ask two things. Are you scared that someone might harm the baby? Or are you, if you have suicidal ideas, what will happen to the baby if you die? And, do you think that, it might be better if the baby also does not suffer and go along with you? Ask these questions, and the mothers will readily, reveal these risks to you. Risk of aggression is also there. But, the most important risks are the risk of suicide and the risk of infanticide. And those things you need to be particularly careful of. So the management of postpartum psychosis is to manage a calm environment and, make sure that the mother is not overstimulated. There's a lot of people going here and there. Put her at least temporarily just near the nursing station and in a little bit of a corner so that she can have some space to herself. Manage the risk. If there is no risk to the baby, initially you can actually, if you're not sure, you can actually give the baby to the mother under the observation. You can ask one of the nurses or the midwives to ask the mother, when the mother is handling the baby, to observe that and supervise. And then you can decide. And obviously, a psychiatry review would be done. And then one of the things you have to ask the psychiatry doctor is whether you can actually give the baby to the mother. Without any reason, don't separate the baby from the mother. In postpartum wards, the support staff is always there, so you can observe the mother till a decision is taken. And of course, antipsychotics are the treatment of choice. And we would consider ECT very early in the management to ensure that the breastfeeding is established, the mother bonds with the child, and there's a lot of problems at home. The husband might be looking after other children at home, might not be able to go to work, might have to get down other support from extended family. So it's very important that this mother is managed very urgently. I am sure most of you would have visited the mother-baby unit of the National Institute of Mental Health. This is the only dedicated mother-baby unit in the country. It's a very nice place where there is a separate room with, an extra bed for the extended family to stay, with separate bathroom for the mother. And, there are nurses who can look after the child. And if the baby doesn't have any problems, the baby can be kept with the mother under the observation. If you think that a patient is going into postpartum psychosis and you don't have a lot of support, keep a responsible bystander to support the patient till a further management plan is established. Feel free to send me any questions on chat, and I would be happy to answer you any questions at the relevant time or at the very end. Postpartum depression, a little bit more prevalent than postpartum psychosis, but less so than maternity blues. Again, the onset is in the early weeks. And, as we discussed, rather than depressed mood, they might actually complain of irritability, anxiety, and feeling tired. And the treatment, and they would have a lot of depressive symptoms, some worthlessness, hopelessness, very poor self-esteem with regards to looking after the child. And of course, there might be helplessness, hopelessness, and suicidal ideation, and exclude the risk to the baby, similar to postpartum psychosis. Ensure that the mother has adequate sleep for them to get better soon. And we use antidepressants, sertraline, which is the preferred antidepressant is sertraline, to prescribe during breastfeeding. And there are other antidepressants that you can use also. And then, support in looking after the baby, and support with other psychosocial issues if there are any risk factors. We all know that the Edinburgh postpartum depression rating scale is now, the EPDS is now available. And on the 30th day postpartum, the midwife will definitely fill this with the mother. And we are getting so many referrals these days where they have detected postpartum depression in the mother. So there are 10 items here, and each are rated on a scale of 0 to 3. And just this copy is not very good because I couldn't really get a good copy of this clear copy. But if you go through on internet, you will actually find the English version, a very clear English version. And this is how it scores, because you have to know how to score it. The score should be higher than 13. And if it is higher than 13, you have to refer to a psychiatry service. And if it is somewhere between 9 and 13, you might have to monitor the mother and do an extra assessment of the mother to see if the mother needs extra support or a referral. The other trick is for the 10th question, which is about suicidal ideation here. If even one is positive, if the mother if that is the only score that the mother gets, even in the absence of any other positives, you have to refer the mother to for psychological support. So that's how you do with the Edinburgh. So lastly, I think this is my last slide. Ask about the mental health of postpartum mothers and pregnant mothers, because prevention is much, much better than trying to intervene in a complicated pregnancy or postpartum period. And that is much better on the mother and the child and everybody else involved, including the extended family. Explore any psychosocial problems. Just when you are clerking, ask, okay, what's your husband doing? Is your husband using substances? Is there domestic violence? Are you having any social issues? And support them in whatever way possible. We know that there is not much support available in the hospital, but just talking about it and supporting the mother is sometimes enough. And if they have an urgent need, if you actually had a kind word to the mother, they would actually come back to you. And that is what we want. Refer for psychiatry opinion if they have a past history of mental illness. This is a very good thing that most of the interns do, and I am really happy when I receive a referral from an intern medical officer, because they had detected past mental illness and they are writing a referral. Don't wait for your consultant. We would definitely accept referrals from you to see if there is a past history of mental illness in the mother. And if the mother is on medication, definitely you need to liaise with the psychiatry team. And the risk factors, ask for the risk factors, be vigilant in high-risk mothers. Some of these mothers, you might not need to refer to psychiatry services, but you might need to monitor closely during the antenatal period and the postpartum period. Hand over properly to primary care. One of the things that we do in our unit is always when a postpartum mother or an antenatal mother is referred, and if we find that the mother needs extra support or further management or further follow-up, we call the PHM and the relevant MOH, and we hand over the mother and ask the PHM to support a little bit more and to observe the mother at home. And this is always very useful, other than, always educating the husband or the partner and the extended family, which is available on early warning signs, on what to look for, to, identify risk and to come back immediately if there are any problems. If you are, actually sending the mother to local psychiatric service, please give a call or write a referral and hand them over to the local service. But is always, the pregnancy record goes along with you, and the PHM or the MOH will turn it and have a look. So put a note in the pregnancy record if you want them to be followed up and given some extra support. Prescribing in pregnancy and postpartum period, antipsychotics are fairly safe, but you know that we usually avoid clozapine. But in a very rare occasion, a mother might be continued on clozapine if the mother happens to become pregnant, because the risk versus benefit analysis shows that taking off the mother from clozapine might actually be risky. Antidepressants, preferably sertraline, during pregnancy time, we avoid paroxetine because of the risk of cardiac side effects on the child. Lithium, refer to a psychiatrist immediately, and you know that the levels will fluctuate in different stages, and during breastfeeding, it's going to be a problem too. Again, if the mother is on sodium valproate, particularly if you find that the mother is in the first trimester, refer to a psychiatrist. We'll change over to another mood stabilizer and make sure that the mother is stable. Benzodiazepine, again, are best avoided. So if a mother relapses because we had not identified her during the pregnancy period, then we might have to give benzodiazepines and antipsychotics, and that is going to affect the baby. So therefore, they are best avoided and we should identify early. So that's it. But I think there was one question, one answer where there was a probability that you had said that it might be adjustment disorder. So you can look at paternity blues as like an adjustment problem. Yes. But it is not an adjustment disorder, because within a few days, it usually the symptoms resolve on its own. And we know that this has a very strong biological basis and is linked with pregnancy, whereas adjustment disorders are usually linked with a stressor, and therefore, even though pregnancy and postpartum, in the postpartum period and delivery might be considered as a really big stressor, it's not really related to that. It's related to more the biological changes in the body, and the maternity blues usually are resolved within a few days' time. Any questions? Over to you, Dulangi.
Thank you very much, Prof. Madhu. So there are no questions for us. So you can also put it.
I have a few here. Do we have to avoid methyl dopa in PIH because of postpartum depression? Not really. I mean, you can do a bit of a risk-benefit analysis and, decide on that. You don't really have to avoid it. And, in the postpartum period, you can sometimes go down on the doses also. So, even with clozapine and lithium, it's not absolute. And sometimes you might take a risk and, prescribe some of these medications. You might have seen them being prescribed. And same with other medications also. You do a risk-benefit analysis. You monitor the mother and decide how it goes. If there is a stillbirth, do we consider as adjustment disorder? Yes. So if the mother shows prolonged grief and the mother cannot adjust to the stillbirth, and if the mother shows depressive symptoms for a long period beyond 6 months, shows features of abnormal grief, then of course we can diagnose an adjustment disorder. If you go through ICD-10, you will realize that abnormal grief reaction, abnormal bereavement comes under adjustment disorder. Yes, but of course, most of the mothers, with the help of medical staff and extended family, with the help of the partner, will adjust to this. So be careful when you diagnose an adjustment disorder, because this is a normal thing that anybody can go through. So we don't want to pathologize that. We will give them the maximum support. And only if you find that the reaction is now beyond the normal reaction, we will diagnose a disorder. That's all I've got, Tulangi, and I think I've run a little bit.
No, that's fine. Okay, thank you very much, Prof. Madhu.
Thank you.
Unfortunately, our next speaker is unable to join due to an unavoidable issue. So I will be doing my session next, because we cannot ask the others to join earlier than we have requested. So I will be doing the session on mental illness in a pediatric ward. As for the previous one, please feel free to ask questions or put your questions in the chat box. Can you all see the screen? Okay, all right, thank you. Yeah, so I will cover a bit about working in the pediatric units, because I'm sure all of you have gone to pediatric wards and seen the setup of a pediatric unit. But when you're actually working there as an intern house officer, it can be a bit different, because most of the time of your day would be spent in the ward, and you'll have more continuing sort of contact with the children and the parents. So it's going to be a little different from when you were medical students. So I just wanted to cover these areas. I just want to sensitize you to a child's experience when he or she visits the hospital or stays in the hospital. And we'll briefly touch on the common mental health disorders in children and when you should be concerned, because sometimes we have seen situations where people are concerned when a child is a bit hyperactive, but it could also be due to so many other reasons. It doesn't necessarily have to be due to ADHD. And I'll also speak a bit on how we can support the mental health of children in the hospital setting. So what do you think it's like for a child to come to a hospital? Any thoughts? Anyone would like to answer or put that in the chat box? How do you think a child might feel when he or she comes to the hospital? One word answer is adequate. Yeah, they'd be anxious, scared. Anything else? Traumatized? Yes, some of these kids are traumatized when they go through a hospital experience. It can be very difficult for a child. So it's good that you are aware that it's difficult for a child. But why does it become difficult? Yeah, the environment is unfamiliar. So that's also going to create problems, because this is a very different environment from what they are used to. So what do you think it's like for a child to be in this sort of a place? Yes, one of you have said that the past experiences can also affect how a child feels. Definitely, because if the child was in the hospital previously and had multiple injections or blood drawings or stuff, then it's going to be very difficult. Just imagine for a child in a crowded ward, there are lots of other children, lots of noise. It's difficult to even get adequate sleep. So it's a very difficult experience to stay in the hospital. And then, of course, the toilets may be a big issue for some children or most children. And then there are these other people, strangers, people who are familiar to them. And sometimes the mother has to stay with them, and then the other kids at home are going to have difficulties. So there are a whole lot of psychosocial stressors associated with an admission. And for the child, it's scary and unfamiliar, like you mentioned, and it may trigger traumatic memories from past admissions. So it's going to be difficult. And then, of course, there's such a lot of other people around. And for a little child, everyone else is taller than him or her. So it's going to be very it's going to be really overwhelming for them. And then, of course, on top of that, we have our procedures and medicines and injections, which is going to make it more difficult. And especially if there has been adverse past experiences, kids are going to scream murder when they come to the hospital. So as intern house officers, you are going to have a difficult time when you try to examine and see children. And sometimes you may get a lot of admissions on a single day, and you will have to examine them, you will have to document, and then you will be really stressed for time. And you may feel that, when a child starts crying, you may become quite annoyed because you are tired, you are hungry, you are sleepy, and you are pressed for time, and you'll probably get an earful from your consultant or other senior colleagues. So it's going to be difficult. I'm not saying it's easy being an intern, but what I'm trying to impress upon you is that it's difficult for the child also. It's anyway not the ideal condition, especially in our hospitals, but we have to work with what we have got. And we are providing good healthcare as indicated by our superior indices in relation to other developing countries. So I think being part of that is rewarding in itself for everyone involved. But of course, it's not going to be an easy life over the next year. Next year at least, that is, yeah. And of course, you will have these behavioral challenges in the ward setting. There will be kids who start, screaming the moment they see you, or just screaming in general. You can't identify why. The mother is also distressed, trying to calm the child. Nothing is working. Child is screaming and crying and kicking. And then, of course, there will be the angry one who's throwing things, who's rolling on the floor, and sort of everyone will start gathering around, and you'll feel really inadequate, believe me, because you can't calm the child down. And everyone expects the doctor to be able to handle the situation. And we can't offer any magic to, make the child feel better immediately. The child is going to throw the tantrum. And sometimes it just will be out of hand. And then some of us may feel a bit inadequate. So I remember when I worked as an SHO in a pediatric unit. And sometimes when we had kids coming in and shouting and kicking and screaming and we couldn't examine, it was so disheartening. But we have to accept that it's okay. Children do kick, they do scream, they do cry. So all we can do is move on to the next child and see this child once they are calmer, or give him or her a little bit of space. Otherwise, we won't be able to get anywhere with that child. And then, of course, the parent will also be in a lot of distress. And then when the kids are a bit older, they'll just refuse to talk to us. I'm sure you would have come across teenagers, or maybe when you were teenagers, you remember how, you didn't want to talk to certain people and you will just not talk. So that also happens. It's not, your fault. It's not the child's fault. It's just that this set of circumstances have come together to create this difficult situation for both the child and us. If you feel it's your fault and you feel inadequate, then sometimes you might project it. You might get angry with the child because the child isn't compliant. Again, that's not going to take us anywhere. So one thing to remember during your internship is, especially if you are doing pediatrics and dealing with kids, you need to be very, very patient. And you need to be able to sort of try and do other things while the child calms down. Otherwise, you won't be able to get your workload done. but it will definitely be challenging, but also rewarding, because sometimes kids who come in screaming and kicking really settle down and develop a very good rapport with you, then that's a lovely feeling too. So it's not going to be all bad, but there are going to be certain challenges. Kids are not going to comply because, as some of you mentioned, they are in an unfamiliar situation, they are scared, anxious, they are traumatized by past experiences. So it's a very difficult experience for them also. Hello, sorry about that. My internet connection has suddenly decided to, leave me stranded. Until I join through my laptop, I'll continue with the presentation. So where did I get cut off, please? Was it when I was talking about the children there in the wards who become, irritable, or? Hello? Can you hear me? Hello? Yeah, okay, all right. Yeah, so I'll go on until I get my laptop working, and then I'll start sharing the screen again. Until then, I can just talk about what I was going to highlight on. So what I wanted to impress upon you is that it's important to remember that kids are scared and they are anxious. It's very difficult for them to engage in this new situation. So it's going to be a challenge for them. And it's going to be a challenge for us also, because we are not familiar. This is a new situation for us. And we are also going to have difficulties, and we are going to be tired and all. But it's important to remember that if we give them enough time, if we allow them enough time, they can engage with us. And we might need to, if a child is behaving in a very difficult manner, we might be able to, oops, sorry. Yeah, I was able to rejoin. So we might be able to help them become calm and engage better with us. Sorry about the technical glitch. So if a child behaves like this in the ward, does this mean that the child has a mental illness? What are your thoughts? Do you think the child has a mental illness if he or she behaves or kicks and screams and throws a tantrum in the ward? Yeah, probably not. It's unlikely. It's just they are reacting to this situation because they can't communicate, they can't express how they are feeling. So they're just going to kick and scream. And they will behave in this manner because of the reasons that we spoke of, them being scared, unfamiliar, traumatized. So because of all these reasons, kids will play up. But of course, there may be underlying mental illnesses, but just because they behave badly doesn't mean they necessarily have a psychiatric problem. And in the hospital setting, the families and children have a lot of issues because it could be related to physical illness. Child may be in pain, they are worried about the illness. And then there may be mental health difficulties. Some parents may have be having depression or other problems. Or the child may be having developmental disorder or hyperactivity or other mental health condition. And children are also at a disadvantage because they may not be able to understand what's happening. They may not have the cognitive capacity to understand, and they may be in a lot of distress. And then parents get information, especially in our setting, everyone tells them conflicting information. From the consultant to the attendant, they get a lot of information, and sometimes even I think the cleaning lady might pitch in and give her opinion. So it's going to be a lot of different sources of information that the parents are getting all these news from. And it's going to be confusing. And then there's huge disturbance to routine when someone is admitted. Now, we don't really think twice about admitting a patient because in our setup, healthcare is free and there are no issues with insurance. So you can just admit if you feel like admitting. But please remember that an admission is going to cost the family a lot in terms of not just money, but also their emotional well-being. Everything is going to be affected. Because just imagine a time when a family member was in a hospital. The whole routine at home is disrupted. So we have to really think carefully when we admit a child to a ward because the whole routine of the family is going to get affected. And then, of course, the effects on hospitalization on mental well-being. The child may be in pain. They may be anxious, worried, and they may miss their routines, family, friends, schoolwork. So there are going to be a lot of difficulties for the kids. And then the families may be worried. They may be really confused. They don't know what to do. And there may be physical exhaustion because we have seen some parents who've been there for weeks and weeks in the hospital and they're just exhausted because they don't even have a proper bed to sleep in and they haven't slept for so long. They're really, really tired. And then, of course, the siblings are there at home. They may be worried. They may have reduced attention from the parents and they may also be affected in terms of their safety. We have seen circumstances where where the mother has gotten, one child has gotten admitted, the mother was the bystander, and at home the other child was not safe, father was going to work. There have been incidents where that other child has been abused. So when we admit a patient, we have to really think of these things and we have to try to keep our admissions as short as possible because we don't want to disrupt the daily routines and lives of the child, his or her siblings, as well as the parents. So how do we differentiate, normal temper tantrums and other emotional situations, other emotions associated with difficult situations from those due to mental illness? Any thoughts? How do you think we can differentiate? So we need to look at whether there are any developmental concerns, whether the child's developmental level is normal. So you need to have a really good idea about your normal developmental milestones. There's no excuse for you not to know your developmental milestones. Then, of course, the patterns of symptoms. So if the child is just running around and not having, other features, and the mother clearly says this is only happening in the hospital, then that pattern isn't suggestive of a ADHD. And of course, like some of you have mentioned, the presence in many settings, we have to see where these are. And then when we are thinking of the developmental milestones, like Nuskia has mentioned, we have to think about eye contact and social milestones as well. And then the level of distress and impairment of these symptoms. If they are pervasive and they are occurring in other situations, they are occurring over a significant length of time, at least a couple of weeks, and then they have been causing a lot of distress and impairment for the whole family. Those things are some of the stuff we consider when we think of whether this is actually an illness or a reaction to a situation. But always remember, when we are seeing a child, we have to have a very good idea about the child's developmental level. Otherwise, it's difficult to judge everything else. Because when we think of hyperactivity, we have to judge that against the developmental level. When we think of their speech and language, again, we have to judge that against their developmental level. And then when we need to be concerned is if there are features that meet the criteria for any developmental disorders, emotional disorders, or behavioral disorders. So for ease of use, we divide child psychiatric disorders into these three categories, but that doesn't necessarily mean that they are like very demarcated. There is a bit of an overlap between these three categories. When we think of developmental disorders, we think of global developmental delay, then specific delays, and also deviations like in autism spectrum disorder. And it's very important that we get a good developmental history. So for every child that we see, we really need to get an idea about the developmental level. Otherwise, we can't comment on anything else. And these are some of the developmental disorders that we see. Of course, elimination disorders are really common, nocturnal enuresis and all. That's one of a common presentation. And if you work in a pediatric setting, you will also see the other developmental disorders. And then the emotional disorders. Again, we have to see if the child is worried and anxious, the severity of that level of anxiety, then the impact and how long it goes on. For example, if it's just during the stay in the hospital, then that's likely to be a reaction to this. But if it's been there for a while, then we have to think whether this is a major psychiatric disorder. And then again, we have to assess those against the child's developmental age. Because say things like separation anxiety are normal at certain developmental ages, from between 18 months to about 3 years. A child will have distress upon separation from a primary attachment figure. But if it's very severe, or if it persists beyond that period that it is normal for, and then that's going to be a problem. Then of course we have the environmental factors as well. Whether we need to see whether it's a clear reaction to an environmental factor or not. And then when we think of the emotional disorders, these are some of the disorders that we see specifically in children, especially separation anxiety disorders, selective mutism. Those are not things that we encounter in the adult world, but of course these are seen among the children. You may encounter these in a general pediatric ward. And of course, you will see children who have been subjected to abuse. And then you'll need to think of whether there are any elements of a trauma-related disorder. Because you will get children with physical abuse, emotional abuse, sexual abuse, as well as neglect. And sometimes the only indicator might be evidence of post-traumatic stress disorder, or the child being really, hyper-aroused, extremely vigilant. And because sometimes the parents also may not come out and say that this child had a, this child is being abused, because the parents themselves may be the perpetrators. Then you need to be vigilant for signs of trauma-related disorders, the psychological signs. Because if you miss during if there is a general pediatric admission for some other unrelated cause, and if you miss this, then that's being quite unfair by the child's, because we have to respect that we cannot afford to miss child abuse. We need to be always vigilant for that. And then when we do have our common behavioral disorders, again, we have to look at the patterns of symptoms. So ADHD comes with hyperactivity, inattention, impulsivity. Then the severity and the impact. So if the child is not doing his studies at all, not writing the notes at all, or getting into a lot of accidental injuries, then we have to think whether the severity is meeting criteria for an ADHD. And then, of course, the duration, because if it's just been there for a couple of weeks in a 10-year-old, then that's unlikely to be due to an ADHD. Then you need to find out what's going on. Something has troubled this child. Could this be trauma related? Because if a child has a bad experience, say a traumatic experience, then they might come out with this sort of symptom. Then, of course, we need to look at the developmental age as well as environmental factors again. Because why we need to be concerned about the developmental age when thinking of things like ADHD is because these kids, the level of activity and the ability to sustain attention is also part of their developmental level. Say, for example, if you think of a 10-year-old, he's able to sit for a 50-minute period in the school. But a 6-year-old in grade 1 isn't able to do that. So that's because they are at different developmental levels. And then, of course, these are the common behavioral disorders that we see, things like ADHD, ODD, conduct disorders. And increasingly, we are seeing behavioral addictions, screen addiction, gaming, and we see these little kids, 2-year-olds, 3-year-olds coming with screen addiction, where they're just allowed to watch screens, and if the parents try to remove the screens, they become really distressed and have temper tantrums, and there's a lot of disruption when the screens are, when the parents attempt to remove the screens. So behavioral addictions are an increasing concern, and you will definitely come across these when you see patients in your pediatric wards. And if you do detect these, please don't hesitate to refer, because we need to catch and manage these early, because once these behavioral patterns are well established, it's going to be a very difficult task to get them off the screens, because then by that time parents are also, having given in for so long, the parents also feel helpless. They don't feel that they have the agency to manage this, and that's going to create a lot of problems. So please refer early if you think there is an element of screen addiction. Some parents also don't realize that, giving their child too much screen time is a negative thing. They think if they are learning the alphabet and how to count and all, even if they're like 2+ and not even looking at other people, then, the parents are quite happy. So we need to let them know that this is not the way to stimulate a child's development. So what can we do? Of course, we need to be supportive. We have to support the children and the parents and try to make the environment a bit child-friendly in the wards. I know some of these wards may be really crowded, but we try to have pictures and toys and things to, stationery, so that they can draw pictures if they like, and try to make it as child-friendly as possible with good lighting and airy spaces, so that the children don't feel congested and overwhelmed. Then, of course, communication. again, we have to get down to their level of communication. They are like, if we tell them all these medical jargon, nothing is going to go in, and they might fear that they have a life-threatening condition and be extremely anxious. We have to tell them in a way that they understand. And same goes for parents. Parents are at different levels in terms of their ability to process information and make decisions. So we need to support them. So sometimes we get annoyed because the parents don't follow our instructions. But that's because they may lack sometimes they may lack the capacity due to cognitive or emotional reasons. They are unable to follow the instructions or remember the instructions. So we need to remember those things during our communications with children as well as their parents. And then, of course, they need a lot of psychological support. By that, I don't mean, high-five therapy, but just being there, making them feel heard. Because sometimes they just feel that no one is caring, no one is paying them attention. Just being there and making them feel heard is what is important, and validating their feelings. Say, for example, when they are really scared, if you just tell them, so, there's no reason for you to be scared, don't be scared, that's not going to help. Because if someone is scared, it's important that you explore why they are scared and you sort of appreciate that it's scary when your child is sick or when you are sick, in the case of a child. But you tell them that you can do these things and give them a bit of control over the situation, because that really helps. And then, of course, you need to refer if needed, and where appropriate, you need to refer to psychiatric units in the hospital. You can, of course, refer parents as well to psychiatric units if you feel that they are having difficulties. I'm just going to touch briefly on managing an aggressive child, because we see on a fair number of occasions that children are given IM injections when they're aggressive. Of course, that may be a necessity, but first we have to try other things. So if we feel that the child might escalate and become violent, we need to have a bit of a space for the child, keep him or her in a corner bed so that it's a little calmer for them. And tell them before you are going to do a procedure, don't take them by surprise and jab them with the needle when they're not looking. We have to try verbal de-escalation first. We have to try and talk to them in a calm manner so that we help them move to a calmer space. And we may use distraction with the little ones, and even with the older ones, sometimes we can. And then if we are using medicines or chemical restraint, we need to go first for oral medicines. And our IM medications are not going to be our first line. So there's a lot of things that we need to do to prevent the situation from escalating to a point where we have to administer intramuscular injections. And of course, if the facilities are there, we can use what we call geographical restraint or seclusion. But of course, that depends on the availability of facilities. Again, like I mentioned, we have to have a very high index of suspicion regarding child abuse. And if you do suspect, please do tell a senior colleague. And prompt action will definitely save lives. And when they are in the hospital, how we can support a child in the hospital setting. One thing is, of course, we have to educate ourselves. We have to be sensitive and know what sort of difficulties a child may be experiencing. That is important, because if we just forget that the child is in fear, if we forget to counter for the fact that the child cannot understand what we are trying to tell them, then that's going to be a difficult encounter for the child as well as for us, because we'll probably get frustrated and angry. Whereas if we do try to educate ourselves about the developmental levels, how to communicate, and how to create a child-friendly environment, then that's going to be a rewarding experience for us when we go and talk to the child, because then the child is going to be more receptive. And we have to try to provide a suitable environment. Again, that's going to be challenging, but I have seen in some wards, they have really worked wonders with the limited resources we do have. And of course, like I mentioned, appropriate referrals are necessary. And we have to always try to work together with the parents, because sometimes the parents will not be very accepting of our management plans. And our general response is to get annoyed and angry, which is understandable given that we are, overworked. There's a lot more patients for us to see. And this mother is saying no to our management plan. Then, of course, we get a bit annoyed. But we have to work together with them. We have to try and find out why this mother is saying this and see how we can support. And then, of course, another important area is caring for ourselves. Because sometimes in the midst of all this work, we forget to take care of ourselves. We forget our sleep, our food, our exercise, our water, hydration. All these things are important. Because unless we look after our bodies as well as our mental health, it's going to be difficult for us to help anyone else or work in a ward setting. It's going to be challenging then. If we are distressed, if we are sleepy, if we are angry, if we are hungry, then that's going to be difficult. So we have to try and work our schedules so that we keep our physical and mental health at the optimal level possible. So there's that possible thing is of course there, because you will have to, your work will be very challenging, and it, like I said before, also it's not going to be easy, but again, it's going to be rewarding and helpful. Yeah, so we need to educate ourselves on these things: normal development, common mental health problems in children, and red flag signs. So, for example, say for autism, if the child is not pointing, not waving bye-bye, and there's no babbling by 1 year, then that's a red flag sign for autism. So there are certain things that we need to learn for different disorders. And then, of course, we have to be mindful of the impact of the environment on a child's mental health. And we have to educate ourselves about parenting skills, basic counseling skills, and communication, as well as ethics and professionalism. We have to always have a very professional and ethical approach. We cannot, blame other people, or talk about people behind their back, or have any unprofessional behaviors, any personal contact with the parents that is unprofessional. So we have to always maintain our professional boundaries. And communication is extremely important, because a lot of the blame that the medical profession gets is due to the deficits in communication. It's not because we haven't worked, but it's because we haven't actually listened to what the parents or the families have to tell us. And when we are communicating with the child, like I said, you have to give age appropriate information, and then the method of information delivery might be different. You may need to use drawings and things to explain. You may have to repeat the information. And when we are communicating with parents also, we have to have a good idea about their ability to process what we are telling them, and their capacity to follow the instructions. We might need to be additionally supportive to certain parents. And then, of course, the environment, a friendly approach. And when we are, we can reassure the child repeatedly, offer support repeatedly. And we have to be as consistent as possible when we are providing care, so that we don't confuse the parents or the children. Of course, there are certain drawings in certain walls that can be pretty dizzying for the child. We recently got our ward painted, and the color the pink that we actually ordered was, I don't know whether it was not available or they used a pink that was left over from another unit. But one of these children that I was seeing, she asked me why we have chosen that color, and I actually said that that's not the color we chose, but we have ended up with that. And she said that it's actually seizure inducing, because that color is really too much. So we have to try and get a nice environment where the kids feel more comfortable and supported. Like I said, we have to always work together with the parents, because if the parents are not on board with our management plan or our diagnosis, then that's just going to be a big mess. We have to always try to get them to engage with us, listen to their concerns. So the key here is to listen to what they have to say. Of course, that doesn't mean you're going to listen to hours and hours of parents trying to ventilate their difficult emotions. You will have to put certain limits, but it's important that we pay attention to their concerns. And then the caring for ourselves. As I mentioned, that's an extremely important part in this exercise. And we need to always make sure that we are supporting everyone else, but at the same time, we also need to care for our mental health as well. And one thing that I wanted to highlight was the need to develop the self-reflective capacity, because that's something we have to learn, and it's a habit that we can learn, and as we move along, it will help us in our careers as well as our day-to-day lives. So self-reflective capacity, if I were to put it simply, means the ability to sort of analyze your thoughts, your actions, and see why you behaved in a certain manner in a certain situation, why you got angry in a certain situation. So you can, so that you can in future have an approach that is more helpful and that will be more fruitful than getting angry and shouting at someone else. Developing this self-reflective capacity is an important part of being a doctor as well as a human being. Okay, so any questions before we move on to the next speaker? You can put it in the chat box if you have any questions. Or you can even ask if you feel comfortable. Dr. Roshan, can you make Dr. Chamara Vijayasinghe host, please? Because I got logged out, so I'm no longer a host. Yes, so our next speaker is Dr. Chamara Vijayasinghe. He's a senior lecturer at the University of Kelaniya and a consultant psychiatrist at the at Teaching Hospital Ragama. So Dr. Chamara has kindly agreed to speak to us on psychiatric emergencies in a general hospital setting and managing an aggressive patient. Over to you, Dr. Chamara.
Good morning, everyone. Is my screen clear and am I visible, and is my audio on?
Yes, your screen is visible. Your audio is also on. Yeah, you are visible too. Yes.
Okay, right. Okay, thank you very much. And first of all, congratulations to all of you for making it to this stage in your careers. It's an exciting time. I'm sure some of you all may be during a difficult time in A-levels or a difficult time during the medical faculty would have thought you all will get to this stage. So well done. Congratulations, and hope you do a great internship and move on to really successful careers. So let's talk about some emergencies which can happen in medical, surgical, gyn ops, and maybe even pediatric wards where you will be working in the next year. Right? These are related to psychiatry, but they will be seen in the wards you work. Right? So it's very important that you are able to handle these situations. Right? how we will do it is I'll give you 5 case scenarios. I'd like you all to type in your answers in the chat box. I won't mention names. I won't scold anybody. The Ragama students will know that I scold them, but I generally don't scold everybody. So please send in your answers and we'll see so that it's a bit more interactive. Nobody needs to speak or put their mics on or videos on, right? So the first patient will be a patient who became aggressive in a surgical ward. Next, a patient with ataxia. Another patient who has come with an overdose of unknown pills. A patient suddenly develops altered behavior after vomiting, and a patient with high fever and rigidity. These are all scenarios you will come across in your work as interns. So read this scenario carefully. A 45-year-old laborer is brought by co-workers and admitted to the surgical ward after being assaulted at work. The nurses inform you that the new patient who was admitted is talking to himself and laughing. When you ask him what happened to the patient, he says that all people are jealous of him, but God will punish them as he is the Son of God. No collateral history is available when you come to clerk the patient. His vital signs are normal other than a tachycardia of 100, pupils are normal, and no head injury has occurred. You are in the process of writing basic investigations when he suddenly assaults an attendant. Right. Now you have this, you're the surgical HO. This patient has come and now he is hitting an attendant, right? These are some of the things you can do. What I want you all to do is type in the order you will do it, right? So an answer like, the answer should be HKF, C4, put all of them in order, right? If you feel making a psychiatry referral is the most important thing, H comes first, then tying the patient, H, comma, F. Okay, I'll give you 2 minutes. Send in your answers quickly. Not directly to me on the main chat. Don't be shy. But thanks for sending. Some good answers are coming in. Can we see some more? Okay, excellent. Right. Give 1 more minute. Okay, so you're on the right track. Those who are sending the answers, keep interacting. Otherwise, you all will also be bored, right? So this is the answer, the expected answer. Not just this is now you all have done with your exams. No, this is not a expected answer. This is what you all have to do in the ward, right? So the first thing is you call other staff and go in. Some of you all have mentioned verbal de-escalation first, right? When you're a doctor, there's certain privileges come to you. People start calling you sir or podi mahatya or podi doctor nona or something, and people generally respect you. And with that, we become confident, which is good. And that is the way it should be. We must be confident. But remember, the psychotic patient who is delusional does not really follow this same pattern as the others. So even though all the other patients are, respectful of you and talking to you, don't think that the psychotic patient or the intoxicated patient will do the same thing. So don't overestimate the power you have. It is a nice level of power to have with responsibility, but don't overestimate and say, I make if in my ward, even if my patient becomes aggressive, I will call attendants, I will call male nurses, I will call medical students if they are bystanders like innanam tamai mama athulta yanne, right? So look after your safety. After that, you verbally de-escalate. Inform your SHO registrar quickly. Tell a nurse to call, right? You have to call security, right? To ease the situation, get numbers, get a bit of power involved, and then you start your rapid tranquilization. Oral, IM, we'll talk about that. You make a psychiatry referral after managing the situation. Psychiatry referral kalla psychiatry MO hari registrar hari enakan hitiyot wage aattuwa disrupt wenawa me gihilla streptokinase vials ema kadaගෙන leda mewa karot the whole situation becomes bad. You have to manage the situation. Just because it's a psychiatry patient doesn't mean you can wait for psychiatry to come, right? Director, police post, those are last. Those are formalities, things legally to cover the situation. Tying the patient to the bed is the last resort. Only if the patient is too risky, till the situation is settled, to help the patient and others, only ekෙන් පටන් ගන්න නැහැ කවදාකවත්, right? And වෙන මොකක් හරි වැඩක් තියෙනවා නම් මේක settle කරලා තමයි යන්නේ, right? So that is how you would settle this situation. And a bit about some lessons to learn. Always look after yourself, right? This is a tough job. You will be tired. There'll be risky patients. Your health is very important. So don't get attacked. Avoid situations like that and look after yourself. If you all work really hard, sleep in the quarters, don't drive and, meet with accidents, things like that. Remember, this is a difficult time. It's an interesting time. It's an exciting time. Every doctor remembers their internship. So do it well, looking after yourself. Seek help. You're a doctor, but you're a junior doctor, right? Get other help for situations like this. Inform the seniors, but you can treat. If there is an emergency, you don't need to wait to give haloperidol. You have the ability. You're covered by doing the right thing, but you have to inform. But inform kalla gollang clinic එකකින් හරි theater එකකින් හරි එනකන් ඉන්ඩෝන් නෑ බෙහෙත දෙන්න බෙහෙත දීලා document කරලා rationally කියන්න පුළුවන්. This is why I gave it. You are perfectly all right. Learn from this experience and avoid future events. How could this have been prevented, right? The patient came with bystanders. Keep them, right? In mental health, this is important. Nurses always chase bystanders away, right? In mental health, in anything, 1 or 2 bystanders, 10-15 දෙනා van එකේ ඉන්න ඔක්කොම නෙමෙයි, ලෙඩා ගැන දන්න එක්කෙනෙක් දෙන්නෙක් ඉන්න එක is always useful, right? For you to get a history, if you want to send an urgent full blood count, you want to do something, it is always better. So when the nurse called and they said මෙහෙම ගහගත්ත කෙනෙක් ආවා කියලා, it would have been better if you, as you take the call, to say I'll come, ආපු දෙන්නට ඉන්න කියන්න, right? If they had said, this problem wouldn't have occurred, right? Nurse ලා කරන්නේ යන්න දැන් අතුල් කරලා යන්න හරි කියලා ආයි 12ට එන්න හරි 5ට එන්න හරි. That doesn't work, right? Get the opinion early. The moment you see the patient, you see that he's talking to himself, talking delusional things, inform psychiatry, tell your senior there is a risky patient in the surgical ward, මෙතනට ගැලපෙන්නේ නැහැ. what do we do? Rather than you writing investigations, waiting, get their opinion early. You can give the medication early, right? Clearly, he is talking something about being gods and powers. There is delusions. You can give the haloperidol early. You have to inform the staff, this patient can become violent. Attendance low, hey, avidino, or risks done. So you're the doctor. You take control of the situation, then this wouldn't have happened. About rapid tranquilization, when you start your medical appointment or your surgical appointment, find out what's there in the ward, right? Every ward will in Sri Lanka will have haloperidol. Even in this crisis, we still have it, right? Haloperidol, 3 milligrams to 6 milligrams. It usually comes in 1.5 milligram tablets or 5 milligram tablets. 3 to 6 milligrams is a good dose, right? Olanzapine thienoanan, 5 to 10 milligrams. And find out what benzodiazepine you have. It's not going to be useful. In Ragama, we have clonazepam, which is fast acting relatively. So we use that. That is there. If the patient refuses medicine, risk go for oral, IM haloperidol 5. We have IM midazolam. See if it's there. Don't worry too much about respiratory depression and all. Then you can give it and monitor. Sometimes we study these things and we think they will happen. We sedate frequently. We never see respiratory depression happening. So look after yourself, but you have to monitor. But don't worry to give it. IM promethazine is also available. You can give all these three, right? And you can go up to a maximum daily dose of haloperidol, right? So no rapid tranquilization will have a bit of idea what's there in the ward. This is your second patient. A 36-year-old farmer is brought to the ward after falling down while working in the fields. His father says he had worked harder than everyone the last few days, and he hadn't stopped work even for lunch. But they noticed him to be swaying while walking. He mentioned that the son had an illness, Snayu Amarua, for which he takes treatment and regular blood tests done. On examination, you notice prominent tremors of the hands. The patient is disoriented in time and place. He is afebrile. The vital signs are normal, and the rest of the CNS examination is unremarkable. Read this scenario well. Your questions will follow. Like the last time, send in answers. These are your questions. What is the reason for current presentation? What is the underlying diagnosis? What is the most important investigation to arrive at a diagnosis? What is the most important treatment you would administer? Scenario again. Send in your answers. Good. Nice answers are coming in. This is the scenario. These are the questions. Okay, 2 minutes. Right. Y'all are improving, y'all are sending better answers, quicker, more people are answering. Okay, well done, right? So you have this scenario, right? So most of you all have the answer. It is dehydration leading to lithium toxicity, right? The most likely answer, right? Given the scenario, you have this person, right, who is taking treatment. People don't use the term mental illness, මානසික රෝග කියන ඒවා කියන්න කැමති නෑ. And regular blood tests කරනවා කියනවා නම් in our field it's either clozapine or lithium, right? You sense a person working harder than normal, slightly abnormal, this increased energy, working in the fields. Sri Lanka is a sunny country, not even eating, he's working so much. So he's not drinking, sweating a lot. Dehydration will lead to lithium toxicity. So the proper answer is dehydration leading to lithium toxicity. What is the underlying diagnosis? It's most likely bipolar affective disorder. I haven't mentioned it. You all have given better answers. It is most likely a manic episode. There's nothing to suggest psychosis here. So it's bipolar affective disorder, mania without psychosis in a patient. You have to do an urgent lithium level. That is the most important thing. And based on that, you will treat it. And there is no major treatment. Is it supportive management? You treat with normal saline. You ask them to drink. You drink water, drink anything, drink a juice, drink anything with salt. If they can take orally, but IV normal saline is the treatment of choice. So you need to treat this, know this. Basic management, identify, start the saline, you have saved the patient's life, right? So a bit about lithium toxicity. It's a dose-related side effect of treatment with lithium. It's more likely if renal impairment is there or in the elderly. Overdoses, if you take a lithium overdose, that's obvious. Dehydration in this patient was the cause. The symptoms are ataxia. So some are swaying from side to side, poor coordination, muscle twitching, surge speech, and confusion. There's altered consciousness. If not treated, it can progress to coma, fits, and permanent neurological and renal damage, and even death. So it's important to manage quickly. Stop the lithium immediately. Overdoses, lithium overdoses, psychiatric overdoses. One thing is, it's obvious. Lithium. Samahalata ammala ළඟ ඉඳන් දෙනවා. අම්මලා bystanders ලා මොකද psychiatrist හරි කවුරු හරි කියනවා මොනවා කරත් මේ බෙහෙත නම් නවත්තන්න එපා කියලා තියෙනවා. So sometimes we are giving and the lithium level is rising to see and we have not communicated with the family, not telling them what's happening, just treating. ඒගොල්ලන් රැට අර කලින් බෙහෙත් ටික දෙනවා. Some people are, some people don't. So make sure that whatever medication they have, you take it and add those appropriately to the drug chart and say අපි මෙහෙම බෙහෙත් ටික දෙනවා. ඔයගොල්ලන් වෙනමකුත් දෙන්න එපා කියලා. That is a risky thing. Patients have a lot of medications. When a patient, not even in psychiatry, when they come who are on long-term medications, get their medication also. Make a list, whatever that can be given in the ward, give it from the ward. It helps the patient with the cost also. නැතිම එකක් තියෙනවා නම් ඒක nurses ලාට dispense කරන්න ළඟායට දෙන්න එපා. Everything becomes messy with polypharmacy and interactions and all these things. Send the urgent lithium level. Over 1.5 millimoles per liter is considered a toxic level. Hydrate well. Ask them to drink water. Salt-containing drinks are better. Normal saline infusion is what is important. You have to monitor the lithium levels and the renal functional tests. Maintain a good urine output. This gets washed out. Books mention, and rarely it might be needed, maybe in the case of a large lithium overdose, where you can dialyze, right? That is like at values over 4. I haven't seen it happen, but be aware of that. And if needed, you can make a nephro referral. Okay, this is your third scenario, right? After this, I think you'll get a tea break. So stay with me, please. You all are doing well. This is a 25-year-old garment factory worker brought late at night by her friends in a hostel to the hospital. She has been receiving treatment for 6 months from a clinic since she had problems with sleep since she broke up with her boyfriend. The friends have noticed her fallen on the floor unconscious, and there is an empty bottle of pills near her. She has written a note to her parents saying goodbye and sorry, and she loves them a lot. She is confused and does not give a proper history. She is febrile. You notice muscle twitching on general examination. Her pulse and blood pressure fluctuate while being monitored. Read your scenario and your questions will follow. Okay. These are the questions. What is the most likely cause for the current presentation? List 3 medications she may have taken as an overdose. What is the underlying diagnosis? What is the single most important thing you will tell the patient's friends? These are your questions. Go back to the scenario. Read this again. Now you all know the questions. Send in your answers. Okay. Start sending, then we can go for tea quickly. Good. Answers are coming. Not enough. Some more, please. Better, better. Very good. Okay, well done. Some of your answers are really good. I hope some of you will select psychiatry. Or 200 people, maybe, I don't know, 10%. Okay, well done. Right. So the answers are, these features are suggestive of serotonin syndrome, right? So read the scenario again now that you all know it's serotonin syndrome, what it looks like. More likely a patient with severe depression, given antidepressants. Unlikely she would have been given antipsychotics. It would be given breakup of relationship, serious breakup. Breakup වෙලා පොඩ්ඩක් එහෙම මෙහෙන් අඬනවා නෙමෙයි. මාස ගානක් කන්න නැතුව ඒ වගේ ඉඳලා she has gone into severe depression, right? And given pills, she has taken these tablets, right? And it's a serious suicide attempt because there is a note saying goodbye, sorry, that's guilt, right? Final act. So this is without telling the friends, right? So all these point to a severe depression with high suicidal intent. The dose is also dose එක ගත්ත ගමන් hina වෙවි ඉන්න ලෙඩෙක් නෙමෙයි ආ මම පෙති ගත්තා කියලා මේකට එනකොට එහෙම ලෙඩෙක් නෙමෙයි unconscious, right? Affecting her metabolically, large overdose. So this is quite a high-risk patient. So these are the features: confused, febrile, muscle twitching, autonomic instability, pulse and blood pressure. So these are features of serotonin syndrome based on the history, right? Okay, so we'll do a bit. Okay, fine. So the answers are: most likely cause for presentation is serotonin syndrome. Medications could be any antidepressant. All antidepressants work by increasing monoamines, including serotonin, right? So anything that can have been given will cause serotonin syndrome. The underlying diagnosis is a severe depressive episode. Because she's unconscious, we don't know whether she was psychotic or not, but we can safely say that she was severely depressed. What is the one thing you tell the friends, right? You tell the friends, what is the single most important thing as an intern to do is, don't keep this girl alone, right? Your ward can be anywhere. In Ragama, the prof unit medicine is on the 4th floor or something, right? There is a girl alone here who is suicidal. She may she will get a bed, but her situation now has not improved. Now the boyfriend is also not there. There are cannulas, there are people. You or the nurses cannot stay with this girl, though it's ideal that if you all can, but you can't. There is another patient who has got a stroke. There is a MI patient who has come. There is another girl with Guillain-Barré. That ward is busy. This girl will not be seen after the initial stabilization for hours till everything gets sorted out, right? You do not want her to jump from that balcony. You do not want her to walk out of that ward and jump onto a train. These things have happened in hospitals, right? You do not want it to happen on your watch while you are in charge of the ward. So once again, keep the friends who came, tell them to call the family. You call the family, tell a nurse to call the family if you are busy, and the family will come from somewhere. They will come. Sri Lankan, you know, if when we are ill, how quickly our parents act. So you can easily get her family down till they come, till there is support, a bystander. You keep this, and that might be the most important thing, though it's the most simplest thing. So sometimes we can reduce complications in our wards by just doing basic practical things. About serotonin syndrome, it's a neurotoxicity syndrome seen when medication used to potentiate serotonin action is prescribed. So any antidepressant basically. It can be caused by high dose antidepressant use. Resistant depression, we give high doses. Combinations. Sometimes we combine drugs to get a better effect. If we increase the dose, or like in this situation, an overdose. These are the neurological features, myoclonus. Those were the jerks, the twitching movements, nystagmus, headache, tremor, rigidity. Psychologically, the patient's confusion is the most common thing, altered consciousness. Fever, sweating, postural instability, those need to be monitored. They can have arrhythmias. Avoiding is important. So prescribers shouldn't prescribe these things. That's not for you. If you see a patient like this, high degree of suspicion, NMS can be similar. You need to distinguish it. But from the history, you know, this is unlikely to have been antipsychotics. So you can, there are more features in NMS, but even in this patient, you can send in the NMS tests as well. Stop the medication. SSRIs have long half-life. So these symptoms will take a long time to act. You need to support the pulse, blood pressure, respiration, urine output. It is supportive management. There are specific treatments like cyproheptadine, also propranolol will help. So you will get a specialist, a physician involved. But from an intern's point of view, it's identifying the thing and keeping the patient stable and stopping the medication. Your consultant will come up with that plan, but you need to identify it and raise this situation as being potentially serotonin syndrome, right? Okay. Next patient, a 20-year-old university student is being treated for fever and severe gastroenteritis. He's on oral ciprofloxacin, IV saline, IV metoclopramide, and paracetamol in the medical ward. You're the medical intern. You're informed that the patient is behaving abnormal. When you examine him, you notice his eyes are rolled up and he is in distress. His neck muscles are extremely tight and he is unable to speak. The patient is thinly built, has a tattoo on his forearm, and on the admission you notice alcohol and cannabis occasional use mentioned. This is your scenario. So think what it is. Okay. And your question is an MCQ. What is your diagnosis? Just send in A, B, C, D, or E. Quick one. Okay, brilliant. So that was too easy. Everyone's getting it right. But bad question when everybody gets it right. But it's an important area to remember and you all need to know this. Okay, so the answer is acute dystonic reaction. There's an important thing. So one thing is there is no antipsychotics here. So we learn about acute dystonic reactions a lot in the context of typical antipsychotics. Typical antipsychotics have extrapyramidal side effects. Those are acute dystonic reaction, akathisia, Parkinson's, tardive dyskinesia. That is the sort of theory we learn. But here you will see that this is not a patient on antipsychotics. It's a patient who's treated for diarrhea. So a lot of medications can cause acute dystonic reactions. Here, the most likely culprit is metoclopramide, which is a commonly given drug, which is known to cause acute dystonic reaction. So it's the clinical features that are important. There are a few lessons here. Learn the clinical features, eyes rolled up, that is an oculogyric crisis, neck muscles are there to a side, torticollis, these are there. These are more features of an acute dystonic reaction. There is nothing to suggest psychosis here, right? So when psychotic patients sometimes get acute dystonic reactions, we think it's a psychosis, patient behaving abnormally. These are more neurological, right? Another thing is people think, right, this patient smokes cannabis, he drinks. We are judgmental. We don't have to judge patients. We need to observe them and go scientifically. So just because somebody has a tattoo or smokes cannabis doesn't mean everything that happens to them is due to cannabis, right? So never be judgmental and make impressions, your own personal judgments. Always go clinically, examine properly, and treat rather than get caught in traps like that. One of the most important things you have to do in discharge, and this is not with regard to this case only, anything, is write on the diagnosis card what happened, right? You can චූටි card එකක් දාලා acute dystonic reaction මෙහෙම ආවා මෙහෙම දවසෙන් ගියා follow up SOS වගේ දැම්මම nothing. In red or like nicely mention that they got this in response to metoclopramide, so they won't get it again. Same with the serotonin syndrome patient, right? Take pride in your cards, right? Sometimes you see your cards even when you are consultants. If you all might come across it. It is possibly one of the best, most important things because we don't have a computerized system, right? And that card will save the life. You won't even know it when they go the next time. For the next doctors, for the other HOs, because there'll be repeat admissions, your information will be there. So write clearly, comprehensive cards as interns, not just for this, but for anything. And that is a large part of being a good intern and helping patients and saving lives. So please remember that, right? A bit about acute dystonic reactions. They usually occur after treatment with antipsychotics, but not only antipsychotics. Young males are more prone. Typical injections, IM haloperidol, depot injections like flufenacin are more likely to cause it. These are the clinical features: torticollis, tongue protrusion, grimacing, opisthotonus. Can be easily mistaken for psychotic behavior if you're not clinically sound. Stop the offending agent. Treat with IM benztropine 2 mg stat. This is the medication of choice. See if it's there in your ward. Other medications which help are IM promethazine helps. If they can take oral, if they can swallow, the dystonia is not so bad. Oral benzoxol, oral benzodiazepines will also help, but they take time to act. Documentation is very important, right? So know about acute dystonic reactions. Last case and tea break. Okay, so do this well. A 23-year-old patient with polysubstance misuse becomes aggressive on the medical ward. Your consultant asks to administer IM haloperidol 5 mg stat and refer to psychiatry. The psychiatry MO starts the patient on oral haloperidol 3 mg BD and asks to transfer the patient to the nearest psychiatry. Prior to transfer the next day, the nurses mention his temperature is 101 degrees and he is not moving or speaking. So read your scenario well. These are your questions. What are you concerned that the patient may have developed? What other signs will you look for to confirm your diagnosis? What one investigation would support your diagnosis? Name 3 medications which would assist in the supportive management in this patient. Back to the scenario for 30 seconds. And your questions. Okay. Last question. Quickly send the answers. Send all 4. A one depa. Hatarama. Be comprehensive. Good. Good answers. You all will be good interns. So that's good. Or good psychiatrists. I keep trying to get everyone into psychiatry. It's a good field. Think about it. Excellent. Okay. Okay, well done. Right. So this is neuroleptic malignant syndrome. Note the difference between serotonin syndrome. The high fever is there. The cardinal features are high fever, altered consciousness or disorientation, a generalized rigidity, and also there's postural instability, right? So these are the main features. Know these features. Creatine phosphokinase is with this clinical scenario, it's diagnostic. I think from an MCQ point of view, nothing is diagnostic, but antipsychotics, all these features, CPK high over 1,000, you have a diagnostic. It's diagnostic of neuroleptic malignant syndrome. It also provides a prognostic value because when we do serial CPK levels, we expect it to come down. If it's coming down, we are happy. If it's going up, we know the condition is still going on. These are the medications you can use to treat it. You treat with benzodiazepines. Bromocriptine is also given. Dantrolene is a muscle relaxant. You don't need to, these are rarely used drugs, so you don't need to know the doses. BNF එක තියෙනවා. IM haloperidol 5 කියන එකට BNF එක බල බල ඉන්න බෑ. You all need to know that. But things like this, which are very rare and specialized, you can the consultant will tell you. You can look at the BNF or treat. So don't worry, but know that these medications are also available. The mainstay is supportive management, right? So NMS, it's a rare but life-threatening condition. About 0.2% of patients treated with antipsychotics. It's very rare. Usually within the first days of treatment. Onset is rapid and starts early after the treatment. The motor symptoms are generalized rigidity, dysphagia, and if the intercostal muscles are affected, dyspnea. Psychological symptoms are altered consciousness, stupor, and mutism. Hyperpyrexia is there, high spiking fever, and autonomic symptoms, unstable BP, tachyarrhythmias, increased sweating, and salivation, urinary incontinence can occur. Complications which can occur: aspiration pneumonia, thromboembolism, cardiovascular collapse from the autonomic problems, and renal failure due to increased muscle breakdown, acute tubular necrosis, myoglobinuria, and acute tubular necrosis. So acute renal failure also occurs. You need to monitor for all of these at once. The mortality if untreated is about 10%. It lasts for about 1 to 2 weeks. If it's a depot injection, it will last longer. If you can find an ICU bed, which you are very lucky, it would be better to manage there. But usually it's managed in the medical ward because ICU beds are a rare commodity. So supportive management in a medical ward is there. So supportive management means manage the fever with paracetamol, tepid sponging, keeping the patient cool, right? Monitor pulse, blood pressure, accordingly give medication to manage those. Maintain a good urine output, do the renal function test, check that they are going okay, seek medical opinion if needed, right? So these are the basic things that you do and which will help the patient. There are specific treatments, bromocriptine, dantrolene, and benzodiazepines are useful. Later on, these are not for you. You need to treat the psychosis or whatever the problem was if it's a psychiatric patient. So methods like ECT can be used. And after about 2 weeks, the psychiatrist decides whether they need antipsychotics. And if so, what do they give? Those are not for you, but that's just a general management. You just need to stop the drug, support the patient, heart, lungs, liver, and kidneys, and the patient will get better with time. So in summary, all interns should be well adept at managing aggressive patients. Predicting and preventing risk is the most important thing in aggression. You feel this patient might be aggressive, you take the necessary measures beforehand. Look after yourself, right? Y'all have done really well. Y'all have to come to this stage. A lifelong of excellence has led you to this state. So you don't want anything bad happening to you. Y'all are precious. The country needs you. So always during this course, get rest, eat well, sleep well when you can. Look after your health. Don't get assaulted by patients or bystanders, and do a good job, right? You need to know, at least have books. Even if you forget this, have a book you can refer to. Neuroleptic malignant syndrome, lithium toxicity, serotonin syndrome, those acute dystonic reactions. You need to know the medications, what to manage it. Aggressive patients, suicidal patients, practically what do you have to do? How do you get family involved? How do you make sure the patient is safe, right? Not going llama or not going missing from the board. Those are important things which interns will solve, not consultants, right? So remember, you have added responsibility which you are capable of handling, right? And always seek help, right? You do things confidently, document well, inform your seniors and treat, and everything will go well, right? So once again, it was nice speaking to you all, and you all have an excellent, bright future ahead. Internship will be very exciting, busy but exciting, which is how life should be. And I wish you all the very best, right? Thank you.
Thank you very much, Dr. Chamara. Are there any questions for Dr. Chamara from the audience.
Normally they don't have questions, but I'm happy to take questions.
Usually they don't have questions. I think we need sort of have a bit of an interactive session anyway.
Yeah. I'm in Ragam if any of you all want to ask anything. Once again, if any of you all want to do psychiatry. I keep trying to say psychiatry here without teaching about emergencies.
Okay, so in the absence of any questions, I'd like to thank Dr. Chamara Vijay for contributing as a resource person for this program on behalf of the Sri Lanka College of Psychiatrists. Thank you very much, Dr. Chamara.
Thank you, Nilange. Thank you, everyone.
You made some time changes and all, and you've been so helpful with that. Thank you. So we'll have the tea break now, and we'll be back in 10 minutes, 11:05, for the next session. Hello. Welcome back to the session. I think people have joined in. So our next presentation would be done by Dr. Sayuri Pereira. She's a senior lecturer in psychiatry at the University of Peradeniya and a consultant psychiatrist at the National Hospital. So at the Peradeniya Hospital. And she will speak to us on counseling patients and breaking bad news. Over to you, Dr. Sayuri. I think people are joining in, yes.
Thanks, Tulangi. Yeah, thank you for that introduction. And I heard that the program is going well. It's a pleasure to be a part of this. Now, before we actually get down to the counseling part of things and breaking bad news, this is what y'all will be like. This is what the working environment is going to be like in a couple of months, maybe. So this is the busy intern and this is the busy ward. You'll be there 24/7, most likely. And it will feel a little bit like this because you'll be sort of running to the clinic, running to the theater, wards, clerking patients, taking phone calls. It seems like there's not enough time in the day to do all the work that you have to do in one day. Okay, it's a race against time. So wouldn't it be easier then if we replaced you with sort of a mechanical version of you? A machine that doesn't get tired, can work without eating, sleeping, probably walk faster than you, can remember things better than you, right? So why don't we do that? What is it that we possess that a machine perhaps doesn't possess? Can the machine understand how another person may be feeling? Can the machine imagine or think what the feelings of the other person are like? Right? See, there is a particular part in our brain which gets lit up or triggered when you notice an empathy triggering situation, right? So it's not just a superficial thing. Empathy is very much a biological thing, and only biological beings possess empathy. The reason you need empathy is because you are going to need a whole lot of empathy when you come to the point where you have to counsel patients and break bad news to patients, which is going to be part and parcel of your job as an intern and beyond that. Until the day that you retire, you will need to be doing this. Not only diagnosing lumps and bumps and depression and thyroiditis and various things. This is also a huge part of all your patients, whether you are just a medical officer, whether you are a DMO, whether you are a specialist, you will need to counsel patients and break bad news. So we'll talk a little bit. This is a very straightforward lecture. You know how to do this. This is just a reminder. In your respective medical schools, you have been taught how to do this, how to counsel patients, but let's just refresh our minds. Okay. So counseling comes from the term consilium, which means to offer advice. This is the origin of the word, just giving advice. But we have somewhat altered it when it comes to counseling in the current context of being a doctor. It's professional assistance and guidance. So we have taken away the word advice. You're not advising. You are assisting and guiding someone. in resolving personal or psychological problems. It may not be psychological, it may be some other issues that you are assisting in and guiding this person. So it's a little bit like blindfolding somebody and then guiding them through a room without touching them. So you just offer guidance, not telling them what to do. It's a guidance. Okay. So those days, this counseling is not a new thing, right? It's not something that psychiatrists have invented, and it's not this modern thing. This has been going on for ages, because we know that when you share a problem, you feel much better. A problem shared is a problem halved. Okay. And so people realized that when you talk to somebody, you feel much better and you feel much more relaxed and able to cope up. So this concept of counseling actually started about 60, 70 years ago, this talking therapy or this counseling. And so it's not only for personal problems, not only for psychological problems, any difficult feelings, thoughts, problems that may be going on with you will be done in a safe and confidential manner. Okay. So as interns, why have we included this into your program? Why are we trying to, teach all how to counsel patients? Is, like I said, this is going to be a life, you mean for your whole life, you will need to be counseling patients. Don't think that counseling is only for patients who have mental health problems. Those are not the only people that need counseling. Okay, so you will have to counsel patients who are helpless. They don't know what the disease is. They don't know what the outcome is. They are feeling lonely. They are feeling homesick. Then, of course, you will have some people who have anyway had mental health problems. Some people with unhealthy habits, sometimes a combination of all of this. These will be the majority of patients in your ward, and these are the ones who anyway need counseling, not people who are depressed only, right? So this is why, because you are the first contact person in a ward as a house officer, you are the first contact person, and patients build a lot of respect and trust with the first contact doctor in the service. So if your counseling skills are intact, right, you can actually guide these people and give the necessary advice. Of course, I appreciate that it's not an easy job. Why? Because unlike measuring blood pressure or unlike drawing blood for a blood test, this takes a lot of time. It takes a lot of patience. Patience can be very difficult. You need to be able to communicate well using verbal and non-verbal communication. You need to be calm. You can't be in a hurry. You have to speak clearly. You have to be non-judgmental. You know what these things mean. No matter how tempting it is, you must know to maintain the confidentiality and make the person feel that you have listened to them. The patient should feel that you have paid enough time and you have paid enough attention and you have listened to their problem. So it's not an easy task, right? And you can also maybe think, oh, why do I need to counsel? It's a waste of time. When you come to hospital, you know what to expect. That's not true. A lot of people are not only the patient, but the family and the relevant, important people in that person's life are quite helpless and they are a bit lost. So you are the one who will have to deal with them. And research has shown that if you counsel a patient properly, it gives a different perspective to their illness. It improves the quality of life and it improves treatment adherence. Okay. Right. So that was a little bit about what counseling is. The next, I think, more important or equally or more important is this thing called breaking bad news. Now I know at Peradeniya we have a separate sort of time allocated during the behavioral sciences module to teach you all about breaking bad news. I'm sure other universities have also touched on this, but let's, like I said, refresh our mind and our memories about what breaking bad news is all about. Okay. So what is a bad news? What is a bad news? Today the electricity will be, from today, President announces that electricity will be cut for 4.5 hours. That's also a bad news, isn't it? Is it that kind of news that we call breaking bad news? Is the bad news in that this light kapano, vaturu kapano sort of thing? No, it's pertaining to your patient. Any news that drastically, suddenly, or negatively alters the patient's view of her or his future. Sudden negative news that will alter the patient's view of his or her future. Anyway, when you come to hospital, you anticipate the worst, you anticipate disability, you anticipate death, not only the patient, but close friends and family of the patient. And we know that the reality is some patients will recover well, some have a not so desirable outcome. Some have diagnoses and prognoses that are not favorable and are undesirable. This is the reality, right? So you, as a house officer, you need to inform the patient, not only the patient, but the family also about this. And this is what breaking bad news is all about. Now, you may have read about this before you came, or you may have heard about it. Now, usually breaking bad news is done by the most senior member of the treating team. So you may wonder why we have allocated this half an hour, 40-minute slot for you all, because you all are the most junior member of the treating team. So why have we done that? The reason is someday you will be the most senior member of the team. Then we can't be tracing you down and doing this lecture for you. So we're doing it once and for all today. The next thing is, if your seniors are not available, if they are at some sort of emergency or they are upheld with some other kind of responsibilities at that particular time, you will have to represent the treating team. Being the most junior person, you will have to represent your entire team. So because of that reason, you must know what and how to do this breaking bad news. It's a very unpleasant task. It's not a pleasant task. So everybody tends to sort of hand it over to somebody else, and you're very happy when your consultant does it for you, because otherwise you have to go and do it. Okay. It's difficult because you don't know how the patient will respond. You are quite sure that there will be a lot of emotions coming out. Negative emotional responses will happen. You know that. And you know that you're going to be the person who is taking away the hopes of the patient. Is it a nice thing to be doing? It's a horrible task, isn't it? Right? Because you don't want to be the unpopular doctor. You don't want to be the doctor that gave the bad news. Unfortunately, you have to do it. It's part and parcel of our responsibilities and duties as healthcare professionals. Okay. I'll tell you what does work. If you have a good attitude. Now, this is what patients have said. Patients have said that if the attitude of the doctor is good, if the message is nice and clear, and if it was done in a place where their privacy was respected, and the doctor answered their questions, then they felt that they could sort of digest this bad news much better. Okay, right. So how do we do it? How do we do it? Actually, most of you all as medical students may have already done this without you realizing. I must say, there is no black and white way of doing this. There's a little bit of fluidity because it depends on from person to person, it may vary, but there are certain things that you must cover. Now, if you are giving an IM injection, there's a particular protocol and an exact way to do it. If you are putting a cannula into the hand, there is a particular technique and a way that globally everywhere, everybody does it the same way. If you're catheterizing someone, there is a standard way of doing it. However, breaking bad news, there can be slight variations between person to person, but to help you sort of keep some sort of structure in your mind, we have a mnemonic. First thing, you know what a mnemonic is, right? Something to help you remember things, a shortened version, so that you will remember what you are going to say. Okay. A is for advanced preparation. You can't just go and just before you talk to the patient, look at the CT report and just go and speak to the patient. You need to take time to prepare for this. What is the clinical information available? At what time am I going to do it? It has to be a private place. It has to be a proper time. There should be a comfortable place without any interruptions. You can't just do it in corridors and with antangala karana bani, isn't it? So you must have a proper place, private, comfortable, enough time, no interruptions. Please make sure that you switch off your phone, or you keep it on silent mode, or you give it to a colleague. Just before you go and speak to the patient, please rehearse it in your head how you're going to do it. Otherwise, patients and family know when you are under-prepared, and it shows. So please don't go under-prepared. Please make sure that you go well-prepared for the session. Okay, all right. B is what? Build a therapeutic environment and a therapeutic relationship with the person you are going to give the news to. Right? It's very useful to ask, I have some information to tell you. How much do you want to know? How much they know already? And when possible, if the patient requires, have some family members present whom the patient is comfortable with. Introduce yourself to everyone. Ask for names, relationships to the patient. Try to remember the names. It looks horrible if you ask for the name and then forget the name. Ask for maybe 1 or 2 names without asking all the 10 people what their names. Foreshadow the bad news. You know, it's self-understood. It's understandable. Foreshadow means give a little bit of an introduction, sort of a warning. I'm sorry, but I do have some bad news to tell you. And then, of course, say that this is just the initial meeting. We will be meeting frequently to follow up on what we spoke. You must build that preamble or that relationship before you actually go to the main part of the breaking bad news. Okay. C is communicate well. Please communicate well when you do so. Like I said before, you can bring this now or you can do it before. Ask the patient or family what they already know, what they understand. Don't use medical terms, technical terms. Like I said, this is going to sort of bring out a lot of negative emotions. So sometimes you may say something, there won't be any response. There will be silence, there will be crying. And it makes you feel very sort of uncomfortable. When you say something and they start crying, it places you in a very difficult situation. So what we do is, because we feel not embarrassed, we feel uncomfortable, we keep on talking to overcome your anxiety. Please don't do that. Give that space and that silence and that little bit of time. When you talk to the patient, you will realize the pace. Pace means the speed. You have to take the patient with you in this conversation. You can't just go at your speed and the patient is still coming to terms with what you said initially. So go with the patient's pace. Please encourage questions whenever possible. You must do that. Right? Encourage them to ask any questions. At any point, you can start off by saying that. And then summarize. You may be giving out a lot of information. And if it is a non-medical patient, non-medical family members, it's that too much of information is also a little overwhelming. So make sure that you summarize what you have said. And like we discussed before, make sure that you have a follow-up plan. So we will next meet on this particular day. We spoke a lot today. These things we spoke about. And let's make sure that we meet on this particular, then and there, set another time and date for the follow-up. Or you can say, this is what I have to say, but my SHO or my registrar or my senior registrar also wants to speak to you. So I will make a point this particular day when it's convenient for them. And you put the follow-up plan also before you leave. Right. I told you it's not a easy task because of this reaction that you will get from the patient and the family. It's never going to be good. So when you speak, you will realize what the emotional reactions are like. And be very attentive to body language cues. Okay? Right? Body language cues. Are they turning away from you? Are they not looking at you? Do they get up and go? Do they keep their face covered? Or are they keen? Do they lean forward and ask questions? So you have to pitch your talk depending on how they respond and the body language that comes with it. Okay. Right. This is also very important. Encouraging and validating emotions. What does validating emotions mean? Validating emotions means telling them that it's okay to feel like this. This is a lot of bad information, negative information, and it's okay that you're feeling upset. That is what is called validate. And also when you speak to them, don't try to be this extremely good, perfect doctor and give them unrealistic hope. Don't say you have to a patient who is having metastatic cancer. Don't say you'll be absolutely fine with treatment because you know it's not going to be. Give a realistic, pragmatic, practical type of hope rather than lying, trying to be popular and lying to the patient about it. And even if a cure is not realistic, offer them some hope and encouragement about the other options that are available. There may be a multidisciplinary team involved. It may not just be the physician or the gynecologist. There may be others on board who have other options to offer. And discuss the treatment options. Say that you will refer as needed. And very important, please don't be too mechanical when it comes to this. Ask about the patient's emotional needs, spiritual needs. Are they okay? Do they have support systems? Do they have extended family, supportive partners, children, relations to help them get through this? Okay. So, like I said, breaking bad news particularly is not easy, but you will have to do it. And when you practice, when you actually do it in reality, it becomes easier with time. So I'm sure you all are very intelligent, you all are very sort of full of enthusiasm and very positive set of students who are now going to be doctors. So I'm sure you will get through this. Some patients will be easier than others. Be prepared for that as well. So all in all, good luck with everything. I will stop my lecture for now, but what I will do is we will maybe take a question or two or any clarifications that you might have. Yes. You can ask me anything that's not a lot of theory here. There's more like a practical sort of thing that you will encounter. But if you have questions, please do ask me. Can see some familiar names also. Yes, faces and names. Nice to see you all. So anything that you want to clarify? Shall I ask you something? Say you have a patient with terminal uterine cancer with secondaries and metastatic deposits everywhere. You know the prognosis is really, really bad. So this lady has a daughter and a son, only 2 children. And the son says, so you speak to them and you sort of break the bad news to them. And the son says, okay, doctor, I think you should let my mother know about it. The daughter says, please don't tell my mother. It will be heartbreaking for her. She doesn't know that it's a serious illness. If you tell her now, it will be too much for her. So please don't tell. Son says, no, please tell her. She needs to know what's happening. It's her body. It's her illness. Who are you to withhold any information from her? Now, what do you do if you are faced with such a situation? Do you tell or do you not tell? Any suggestions? How you can proceed with such a problem? These things happen, okay? These things happen very frequently. Kiyan depa, ane please kiyanna nae kiyan depa. So whose side are you going to take if that happens? What can we do if that happens? Yes? All right. I have some answers here. I'm not going to read your names. So assess her mentality first. Okay, good. Yes. So some of you are saying assess the patient's mentality. Okay. Some are saying you have to tell, you are obliged to tell the patient. Okay. Who is the most important person, the daughter or the son or the patient? That is the first thing you must ask yourself, isn't it? Who is the most better to reveal to the patient? Patient is the most important. I have getting a lot of answers here. Better to tell the patient. Tell at another time, not immediately. Tell after you have assessed her. Okay. Unless the patient is of such unsound mental, if your patient is mentally completely unsound, unless that is the status, you are obliged to tell her because your patient is your most important client. Because if the patient has 10 children, 10 of them will tell 10 different things, right? So it is your obligation actually to tell the patient. You can always ask, I have a little bit of bad information about your illness. Do you want to hear it? Don't have to balahatkareng sort of tell the patient. Most of them will say, yes, doctor, please tell. So that's the way to go. Take cues from your patient. Please don't do things simply because you are pressured by the family. And don't fight with the family and don't argue with the family if they are pressurizing. That also happens. You have pressurized so much that You argue with them and you fall into various arguments with the family, which is unnecessary. So hope that's clear. Yes, hope that's clear. No more questions? No? If you have questions, you can type it in. Thanks, Tulangi. I think I'm done from my side.
Thank you very much, Dr. Saire, for joining this session. The next session will be conducted by Dr. Sajeevan Amarasinghe, consultant psychiatrist at the National Institute of Mental Health, Angoda. And sir will be speaking to us about liaison psychiatry when we need to refer to a psychiatrist. Over to you, sir.
Okay. Can I start sharing the slides? Yeah.
Yes,
Yeah.
sir. I have made you co-host. You should be able to.
So we are well on time, no? We are well on time.
Yes.
Okay. So, okay. Can you all hear me? Tulangi, can you hear me?
Yes, yes. And we can see the slides also, sir.
All right. Okay. Let's do this. So I think my task is quite easy because the lecturers before me have spoken about almost all the major illnesses. Maybe. So what I will do is I will just introduce you, talk to you about referral and things like that, and maybe touch upon 2 or 3 common conditions which were probably not covered, like anxiety, depression, and somatization, which are very common in the briefly in medical and in non-psychiatric units. Now, the role of an intern now can vary from where you work. I mean, if you are in a teaching hospital, your responsibilities nowadays might be less, but whereas if you are working in a base hospital with maybe an SHO and a consultant, house officer has a probably major role to play. But even in a teaching hospital, in a very busy medical or a surgical unit, it is the intern house officer in the Sri Lankan setup who actually will pick up things up. So sometimes if the house officer misses it, then nobody might get it. So the intern house officer has an important role in picking up patients with psychiatric illnesses and referring them on. So, of course, nowadays, psychiatric services are available in almost all the general hospitals and base hospitals. So, if you are working in a major general hospital or one of the bigger base hospitals, you will definitely have a consultant psychiatrist and a team. Sometimes in the smaller base hospitals, you may have a MO mental health who will help you with the referrals, right? But as you know, those in Sri Lanka know, some of the major general hospitals still don't have psychiatry wards. So many of the psychiatric patients might get admitted to the medical ward or even the surgical ward. And in that situation, you may have to manage them in consultations with the psychiatrist. And sometimes it is the intern medical officer who may have to actually face up to the psychiatric emergency. I think that's why we are doing this program, and I think those things have been told earlier. And also some psychiatric wards may not take direct admissions because the bed numbers are limited. They may not take direct admissions, and so initially it'll come to the medical ward and then they will refer it on. So that's why so many patients with serious psychiatric illnesses may present to medical casualty units. But my lecture is not about that. My lecture is probably be more about this liaison. But just to add on that it is important to liaise with the psychiatric team regarding the diagnosis, inpatient treatment, and follow-up. And I think so sometimes the diagnosis cards may not be correct, and so it's you need to look at these patients and maybe liaise with the psychiatric team and also arrange follow-up. So it may be sometimes the psychiatric illness, the patient may come with a myocardial infarction or something else, and the psychiatric illness probably not be a main issue. But it's important that you at least arrange a psychiatric follow-up, sometimes that which may have been neglected. And those of you who have done psychiatry as final year, would know that all psychiatric patients are not aggressive, and some of them actually can be managed in the medical ward with the help of the psychiatrist, right? But of course, if the patients are aggressive, then you may need to transfer to the nearest psychiatry ward. And in that situation, it's best to do it in liaison with the psychiatry team. Of course, there are many patients with medical problems that will have comorbid psychiatric illnesses, and like depression, anxiety, substance use, dementia, or even postpartum depression. So this is where the bulk of the liaison work will come in. And some of the conditions have already been described, and I would talk about depression and anxiety a little bit later on. And this is again where I would see the role for the HO to pick these things up. So all aggressive patients are not psychotic, and that's, I think, is very important. When we were house officers long ago, before psychiatry was a compulsory subject in the final year, knowledge about psychiatry was very little, and even everybody who was aggressive was labeled as psychotic, and and some of the patients are neglected, and we need to very carefully exclude organic issues. And I think delirium is most often medical, either some underlying medical cause, or there may be an underlying substance withdrawal. So delirium needs to be picked up, and also encephalitis can present with changes in behavior with fever. So when there are signs of organic etiology like fever, headache, and vomiting, the patient is not oriented for time, place, and person. So if there's clouding of consciousness and the patient is not oriented, if there are visual hallucinations, fluctuations in the conscious level, all that should strongly point more towards an organic etiology, at which you need to understand. Of course, you can get this help of the psychiatric team in calming down the patient, right? In calming down the patient, in sedating the patient, but we may need to exclude the medical causes. And of course, even very late onset illnesses, like we need to think of, usually the major psychiatric illnesses are onset like schizophrenia, bipolar in the 2030s. So when there's very late onset also, and very acute symptoms, again, we need to think of organic things. And I can remember, in the 10 years I worked as a general hospital psychiatrist, I've seen many situations where these have been unfortunately missed, right? And one of the, I think, there was one anecdote I can relate is one in Tangol, when we were working in Tangol, and one patient with alcohol, developed alcohol, admitted to the medical, or I think the surgical ward with an accident, developed alcohol withdrawal, delirium, but nobody picked it up, and it worsened, and he actually ran away from the hospital and jumped into the president's house, which was the then president's house, which was close by, and nearly got shot by the army, right? So, but he was lucky to be escaped. So we have seen so many situations where these deliriums, especially alcohol withdrawal delirium, and are not picked up. So, and this could be life-threatening, right? So do not just brand them as psychotic, and need to differentiate between the delirious patient and a psychotic patient, which I think is very important in a busy medical ward, because if the house officer misses it, it might be missed forever. And I think I can still remember one very over-enthusiastic house officer when we were house officers, in one of the NHSL wards. On admission decided it was a psychiatry referral. And the next day when the consultant came for the ward round, he said, "So this is a patient, psychotic patient, we're going to refer to psychiatry." And the consultant was a little concerned. The patient was still. He took the pulse, and and the patient had actually passed away. And he was awaiting signature for a psychiatry referral. So I think, of course, things are better now. I think in the final years having done psychiatry, but still be aware of the danger of labeling people psychotic when they're delirious. Then, of course, you will have to deal with a lot of deliberate self-harm. I think Dr. Gihan Abeywadana would have done a very comprehensive lecture in the morning, right? So do we need to refer all DSH to the, I mean, it's probably up to you. If the risk is high, if it's a planned attempt, if it's a planned attempt, if there's an underlying mental illness, the risk is high, definitely immediate psychiatric referral is needed, right? But if the risk is moderate risk and there's family support and more towards impulsivity, then you can safely, probably with the help, guidance of your seniors, safely send them for clinic referrals, right? So to the psychiatric clinic. And of course, if there's very, very minor issues, more of, where there's no psychiatric illnesses involved, you can even send to the counseling. Many of these hospitals will have what are called Mithuru PSA, right? Counseling centers run by medical officers. Mithuru PSA, and there's another one, I can't remember the name, but the other one, Yon PSA, Yon and Mithuru PSA. So you can, if there's very mild issues, interpersonal issues, they can actually send to those people as well. So, but do not neglect the deliberate self-harm, because even if it's an impulsive attempt, there could be, and there's no clear psychiatric illnesses, there could be underlying personality problems or issues which, if picked up early, can be addressed to some extent. So, of course, don't overload the inpatient team by psychiatric team by referring everything immediately. You can always triage it, right? And send some of the others to the clinic. You can always liaise with the psychiatrist in this situation. So it's best to have some kind of psychiatry assessment, if not immediately, at least a clinic one. And of course, as with the other psychiatric referrals, you may need to be a little, take a little time if you have, and explain to the family, because sometimes still psychiatric referrals, people don't go. So in that situation, sometimes it's better to get the psychiatric doctor to come and see at least once, because if you feel that the patient is really not going to go to the clinic, although you're going to refer them. Of course, in the outpatient setting too, I'm sure, of course, the outpatient clinics are very busy. I'm aware that medical, surgical, most, I don't know, during our time, the medical clinics, all they did was just check the blood pressure and write the prescription. But wherever you have time, you may, if you actually talk to them, you may find that a lot of patients have underlying medical problems, psychiatric problems, especially when they're not getting well. There may be underlying depression, anxiety, substance use, dementia. So it's very good if you can pick them up and refer to the psychiatric clinic. And as I said, sometimes it's difficult to get them to go there. So we may need to educate the patients and the family members. Of course, as house officers, you might have to deal with social issues. And now with the 1990 ambulance, which is a very useful thing, you may also get a lot of homeless people brought in. And invariably, they'll be either in the medical casualty or medical ward, or if they have a little wound or something, they'll be in the surgical ward. And they'll be homeless. Some of them have no families, no income. So what do? I mean, it's a house officer's nightmare. So in this situation, you can get the help of the psychiatric team, especially most psychiatric teams nowadays have psychiatric social workers or community psychiatric nurses. So you can get their support in trying to help these patients. And some of them, there are, if the patient having disabling mental or physical illness, we can arrange a payment of 5,000 rupees per month, which is, I mean, reasonably large amount for some of these very poor people. And of course, long-term stay homes and long-term care is very difficult to get in Sri Lanka, but the social workers can always help you with this. And another type thing that you might have to come across is consent to treatment. Of course, some patients with psychiatric illnesses that might impair their capacity to consent to surgical and medical treatment. Now, of course, just because somebody has a psychiatric illness, that doesn't mean that they are unable to consent. Somebody with schizophrenia or depression or even bipolar in remission might be quite able to give consent to psychiatric treatment. But if you feel that somebody is not giving consent, and if you feel that this issue is probably to do with a psychiatric illness, maybe schizophrenia, maybe depression, maybe bipolar or dementia, then you can always get the help of the psychiatric team to assess their competence or ability, capacity to give consent. And I'm sure you know about, but just it's about, it's even though you may have the illness, if the patient has the ability to understand, return information about the illness or believe this information and use it to make an informed choice. So somebody may have schizophrenia, may be treated even at NIMH or somewhere, but patient can give consent if he can understand the illness, and he may be able to give consent. But if you believe, like for example, a delusional patient may not give consent. So in that situation, you will have to seek the help of the psychiatrist. So much for the general things about liaison. Just a few words about depression, anxiety, and to finish things up about unexplained medical. So I'll just run through this. I'm sure many of you are familiar with these things. So depression classically presents with low mood, not your ordinary sadness, but pervasive low mood that lasts throughout the day, no improvement with pleasant events, and sometimes worse in the morning. That's the low mood that you get in severe depression. And of course, you get reduced energy, lack of interest and enjoyment, negative thoughts, guilt, low self-esteem, suicidal ideas, poor attention and concentration. So these are some of the, I'm sure you know all these, right? Disturbed sleep and appetite. Of course, there can be atypical features like excessive sleep and increased appetite as well. Of course, the diagnosis will be very easy if patients presented like this, but unfortunately, the presentation will vary. And most patients don't have all the textbook symptoms. And many Sri Lankan patients are reluctant to accept psychological symptoms, and many believe depressive symptoms as a sign of weakness. And so, especially the males, and then they will focus more on somatic features. And so you need to be able to see beneath those somatic features and pick up the depression that might be underneath. Of course, they may be readily accepting things like lack of sleep. They may say they only have lack of sleep or lack of appetite or lack of energy or loss of weight, right? They may tell these things. They may not tell the others things. And of course, they may have common somatic symptoms like headache, pain in the neck, back and shoulders, and burning sensation. And burning sensation in the chest and the burning sensations all over the body could be a very common symptom in Sri Lanka. Abdominal and chest discomfort, fatigue, excessive concern about illnesses like cancer or AIDS, repetitive fear about these illnesses. They all can be presentations of depression. And in mild depression, so depression in mild, moderate, and severe. And mild depression, the patient not be objectively, obviously dejected or slowed. So they may not be obviously slowed or depressed. Usually they might present with things like irritability, where they lead into problems at work and home, increasingly irritable, very poor frustration tolerance leading to anger outbursts, fatigue, lack of energy, and also poor concentration and poor memory. So it's very common in the elderly people with depression to come with poor memory. Even for young people, like, of course, sometimes even young people, university students or A-level students will come and say, my memory is poor. And where most of the time it will be due to anxiety or depression, leading to poor attention and concentration, leading to poor memory. So symptoms are less intense. And even the biological symptoms like poor appetite, weight loss, and low libido may be absent. So this takes a little bit of experience to pick these things up. Alcohol dependence. Of course, many patients might present to you with alcohol dependence, both in the medical as well as the surgical wards. We keep in mind that depression is quite common in alcohol dependence. And it's good to reassess the mood after the patient is detoxified, not when he's intoxicated or withdrawal. It's difficult, but when he's, so many of them may be having underlying depression. As I told you, those who come with deliberate self-harm may have underlying depression. Some of them, not everybody, but some of them. And depression in the elderly. Now, elderly depression, as I told you, might present with poor memory. In that situation, we need to differentiate it from dementia. And of course, in the elderly, they also may have very prominent agitation, where we call it agitated depression, or they might even be psychomotor retarded. And just to add, elderly depression can sometimes be quite difficult to treat. Of course, childhood depression, I'm sure Dr. Dulangi is going to deal with that in the next lecture, so I'll just let it go. So you have childhood illnesses. Severe depression. Of course, when the depression is very severe, it's not difficult. I mean, the symptoms are there with greater intensity. You get functional decline, neglect of food and hygiene, and psychomotor retardation. And as you know, you might get psychotic features with depression. I'm not going to go into detail. You might get hallucinations, which are of depressive nature. You might get delusions, which are in keeping with the depression. I'm going to go with details. So the assessment of the depressive disorder would include the diagnosis, severity of the depression, the severity of the risk, causes, the patient's social resources, and the effect on others. So I think as house officers or as young doctors later on, I think you will have a great, you can play a great role in identifying these patients with depression. A few words about anxiety disorders, which again is quite common illness. So generalized anxiety, phobic anxiety, and panic disorder. Generalized anxiety is a continuous anxiety, usually may fluctuate in intensity, whereas phobic anxiety is intermittent and arising in particular circumstances. Whereas panic disorder is a more of an intermittent anxiety unrelated to any circumstances. So in anxiety, again, you get both psychological symptoms and physical symptoms. And people usually focus on the physical symptoms and very commonly presents to emergency departments as well as medical casualties with these panic-like symptoms. So I won't go into much details about generalized anxiety. They are persistent symptoms, not restricted to any circumstances. And you get severe worry and apprehension, psychological arousal leading to irritability, poor concentration, sensitivity to noise, sleep disturbances. Usually it's difficulty in falling asleep, whereas in depression you get, classically in depression you get early morning awakening. Here you get difficulty in falling asleep. In phobic anxiety disorders, of course, the symptoms occur in only specific circumstances associated with avoidance and anticipatory anxiety. But I'm probably more focused on panic disorder, which are sudden attacks of anxiety. And the physical symptoms predominate, and the patients fear serious medical consequences. So many of them rush to the medical emergencies or casualty. Shortness of breath, choking, palpitations, chest discomfort or pain, sweating, dizziness, unsteady feeling, nausea, abdominal tendons, distress, numbing or tingling. So you need to identify panic disorders. And of course, they get this flushing and trembling. They fear they might die or lose control or go crazy, right? So, and the attacks occur out of the blue suddenly, and usually not associated with the phobic stimuli. You might get phobia, especially agoraphobia with panic attacks also, right? But here you can also get panic attacks in patients with other anxiety disorders and depression as well. But here I'm talking about pure panic disorder. So I think as house officers, you need to identify these patients, maybe give immediate treatment, maybe with consultation with your seniors of some short-term benzodiazepines you can use, but to refer them on for management. Otherwise, they keep on coming for, to medical casualties, repeated ECTs, repeated nowadays, not just ECGs, echoes, and Holter monitoring repeat. Of course, we need to exclude the medical causes. We need to make sure that the medical causes, cardiac causes, all that is excluded. But once that is done, if they are coming repeatedly, then we need to refer them on. And finally, I'm sure you would have learned this in medical school, but just to recap, unexplained medical symptoms. Now, many patients present repeatedly with physical symptoms without any medical cause. And here, of course, first of all, we need to look for underlying depressive and anxiety disorders, and also look for psychological and social disorders. Do not treat them as a nuisance. I know it's going to be very taxing on you all when these patients repeatedly come, and sometimes doctors lose their temper, but we need to be aware that they do have some kind of distress, and that they're not, most majority of the time, they're not really conning or malingering. There is underlying distress. So most of the time it arises from misinterpretation of normal body sensation as a sign of disease. So there's a slight pain somewhere or slight, very small symptoms they need to focus on unnecessarily and misinterpret those symptoms. And when they become anxious and focus on that, these symptoms become troublesome. And this concern leads to increased attention on the sensation, leading to apprehension, anxiety, and maintenance of the symptoms. So there is some mild symptom which they misinterpret, focus overly, give excessive attention, leading to these issues. So what are these body sensations? It could be sinus tachycardia, it could be benign arrhythmias, just mechanical chest pains, fatigue, or autonomic symptoms of anxiety like palpitations, or even just after overeating, they may get, the feeling of fullness and things like that. Effects of lack of sleep. All these could be misinterpreted as signs of disease. So how do you manage these unexplained symptoms? Adequate medical assessment, of course, is needed, right? And a clear explanation of the results, purpose and the results, and why it is concluded that there's no medical cause. But we should accept that the physical symptoms are real and that we should look for others. I mean, don't say that you are a corner or right? You accept the disease, distress. You need to validate that the symptoms are there to some extent and you are distressed, but there's no medical explanation for this. It could be something else. And gently probe about the role of psychological, explain the role of psychological factors in all medical illnesses, and gently probe to see whether there are anything psychological. So I know you don't have time, you're busy most of the time, but maybe not as house officers, maybe even if you as house officers, maybe once when you're actually practicing as doctors or general practice or in your general practice, or when you practice as senior house officers, you can do this. So the first thing is to try to broaden the agenda. The patient is focusing on the physical symptoms, thinking it is totally a medical illnesses. So we need to just make the patient think, at least, that there could be something else, that there could be a psychological explanation for these symptoms. If you can do that, that's a big step forward. And then later we can explore the presence of any ongoing psychological stressors. And of course, if it is chronic and recurrent, offer psychiatric referral. I'm sure many of them will refuse, but we can offer psychiatric help. And if there's clear underlying depression, of course, in patients, we can always get the patient psychiatrist to see the patient, but especially in outpatient, referring them on is going to be very difficult. And if there's really truly underlying depression, if you identify underlying depression, maybe you may have to start the first line antidepressant like an SSRI, because they may not really go to a psychiatrist. Okay, so that's about all. And any questions? I hope I've kept to the time. Oh, I've done it earlier. Okay. Any questions? I know you had a long day and you want to. You had a long and they probably want to finish. But if there are any questions, you can. I'm always happy to answer.
If there are any questions, you can also put it in the chat box.
Okay, Dulangi, I don't think so. We'll give a little time.
Okay, sir.
Yeah, I don't think that they must be tired after a long day, So yeah, the last unenviable task of the last lecture. Yeah.
No, sir, we are done because Unfortunately,
Huh?
yes, because unfortunately, Dr. Amila Isru couldn't join. He was not well. So I took up his slot because otherwise they'll have to wait for half an hour without any activity.
So now it's finished all over now.
Yes.
So you have come in earlier, right? Okay.
Yes. We have finished a bit early because we started early around 7:30.
Okay, right. So they are finished. So 12 is not bad, right? Okay.
Yes.
Thanks to Lanky then. Thanks.
Okay, thank you very much, sir.
All the best for your internship. They are starting soon, is it? Or okay. So all the very best. Okay.
Thank you very much, sir, for joining us and supporting us in this workshop. So I think we can end the session for today then. We are finishing quite early.
Okay.
I hope you have a good afternoon and all the best for your internship. So are you starting within the next few weeks or? I'm not very sure. Yeah. Okay, so good luck and hope you have a productive internship and you also manage to have a nice time during that time. Okay, thank you then.